Good evening,
Okay.
everyone.
Good evening, Swati. And over to you, Dr. Vijay Lakshmi. We should start on time. Over to you.
Okay, sir. So, a very good evening to one and all. So, a very warm welcome to everybody once again to the RSSP Academic Webinar Series 2020. And today's session being organized by RSSP Puducherry. So, a world where no one dies from cardiac arrest is the vision of the American Heart Association. And in November 2020, the latest CCAHA CPR guidelines were released, as we all are aware of. And the Indian Resuscitation Council too has a vision and develops guidelines relevant to our subcontinent. In this context, we wish to have a session covering certain interesting aspects of CPR by a kind of a revisit with all the eminent faculty participating in this evening academic discourse. With this introductory note, I wish to welcome all our patrons, respected President S.P. Sharma sir, our Secretary Naveen Malhotra sir, the founders of RSSP, HL Kaul sir, Tej Kaul sir, past presidents Avatar Singh sir, Yatin Mehta sir, President-elect Indrani madam, Vice President Sharbari Swaika madam, Editor Jugrewal madam, Treasurer Sunil Sethi sir, Joint Secretary Vishal Singla sir, and each and every governing council member RSSP National. Welcome you all to this RSSP academic session. Welcome to all the delegates who have logged into this webinar from the entire world today. We have delegates who will be logging today even from outside India too. I wish to extend my warm welcome to each and every faculty, speakers and chairpersons who joined today. So each one of us by name. So welcome you all. Now I would like to request our secretary sir to speak a few words because the president S.P. Sharma sir is having a meeting, so he won't be able to join us. So I hope my screen is being shared, sir.
Yes, definitely.
Is my screen?
So, on behalf of Research Society of Anesthesiology Clinical Pharmacology, I welcome you all to today's webinar on CPR Revisited, which is being organized by the RSSP Puducherry branch. And it's an excellent topic, and lots of discussions are being held in the field of CPR, especially in the COVID pandemic. And today we have amongst us speakers from all across the country and abroad also, and very experienced team of Indian Resuscitation Council also, which will be chairing these sessions. So I really welcome the speakers, Dr. Swain, Dr. Sai Saran, Dr. Swati Chabra, and Dr. Nibras from US, Dr. Neha Singh, and they shall be deliberating on different topics: CPR in pregnancy, COVID and CPR, prone position CPR, focus in cardiac arrest, and debriefing post CPR. And they will be moderating by eminent chairpersons Dr. Vijayanand, Dr. Suman Lata, Dr. Pankaj Kundra, Dr. Chandrakant Patel, Dr. S.S.C. Chakra Rao, who is chairman of Indian Association Council. And I'm very sure with this COVID pandemic, the Indian guidelines on association, they are helping all the citizens and all the anesthesiologists across the country. And also the motive of that every citizen is a lifesaver. Dr. Shri Lakshmi, Dr. Indrani Hemant Kumar, the president-elect, and Dr. Rakesh Garg, who is the GC coordinator for this particular webinar also, and then Dr. Gopinath and Dr. S.K. Singhal sir. So I congratulate Dr. Vijay Lakshmi, Dr. Joseph sir for organizing this webinar on a very important topic. And I'm very sure that all the delegates will be enriched by the by the words of wisdom by the eminent speakers and the deliberations by the eminent chairpersons. So wish you all a very happy and interactive academic event. Long live RSSCP. Thank you.
Thank you, sir. So with these words, I wish to now welcome our organizing chair. Request him to say a few words. Dr. Joseph Rajesh sir is the professor and head of Department of Anesthesiology Critical Care at the Indira Gandhi Medical College and Research Institute, Puducherry. And sir, I request sir to speak a few words and welcome everybody to this webinar.
Good evening, everyone. On behalf of RSACP Puducherry branch, as well as Department of Anesthesiology, IGMCRA Puducherry, I would like to welcome everyone on board for this wonderful evening and the webinar. We know that as anesthesiologists, the crux of our resuscitation as well as the management plans center around our knowledge on CPR. But to improve it further and also to enlighten us about the advances in the field, especially in this present COVID pandemic and COVID era, today we have got very great speakers, eminent faculty along with us. Sir has already mentioned each one of them has been is there with the name and along with the chairperson, so I don't want to repeat the name. So I take this opportunity to invite every one of you, the faculty, chairperson, as well as delegates for this wonderful webinar, which is definitely it's going to be a great scientific feast. So thank you one and all. I welcome you all. Long live RSAP. Over to you, Dr. Vijayalakshmi.
Thank you, sir. So with these words, we'll straight away start with the sessions. And for the first session of today for CPR in pregnancy, so I would like to share a few words about our eminent chairpersons who are there with us today. Dr. Vijayanand sir, Professor, Department of Anesthesia, Kempegowda Institute of Medical Sciences and Hospital, Bengaluru. He was the organizing secretary of ISACON 2019 Bengaluru, President ISA Karnataka, and received the Proficiency Award 2016. Chairman ISA Karnataka Varchicon 2020, we just finished a few days ago. Secretary ISA Bengaluru Metro, and 5 consecutive years Best Metro Branch as Secretary, with 10 publications to his credit, and areas of interest are surgical critical care, regional anesthesia, and interventional pain. Welcome to you too, sir. And for the next chairperson, we have Dr. Suman Lata Gupta, Madam, Additional Professor, Puducherry. She's got a prize in North Zone 2018 and presented various posters and papers internationally in Ireland, Indonesia, Tokyo, and she's faculty for various shops, including management, and she has got publications international and 20 national to her credit, with the areas of interest: transplant anesthesia, simulation, teaching, airway management, and ultrasound nerve block. Welcome to Madam. So now I would hand over to the chairpersons to conduct the sessions and introduce the speaker of this session. Unmute yourself, sir. Vijayanand sir, unmute yourself.
Hello.
Yes, ma'am.
I would be loving to introduce the first speaker, Dr. Animesha Swan. It was 15 years back. The memory becomes very fresh when she was working as a senior resident with us in JIPMA. And as always, she is a very bubbling, energetic, hardworking, one of the best senior resident who I have worked with, and it was nice giving a very nice topic, and it will be very interesting. She is presently working as a senior consultant, Department of Anesthesiology, Kalinga Hospital, Bhubaneswar, and faculty at various conference, master trainer in AHA. Area of interest is cardiac anesthesia, critical care, obstetric anesthesia, and pediatric anesthesia. Welcome, Animesha, and we would love to hear you.
Thank you, ma'am. Good evening. Good afternoon, everybody, and warm regards from Bhubaneswar. And it's a great pleasure and honor to be speaking among such esteemed guests and faculties. And thank you for giving me this opportunity, Vijaya. And okay, in today's academic session on CPR Revisited, my topic will be on the CPR in pregnancy. I'll be speaking on that topic. So I'll be sharing my screen. Are we ready to go?
Yes. Yes, please.
Yes, yes, we can.
Well, cardiopulmonary resuscitation in pregnancy. Cardiac arrest in pregnancy presents as one of the most challenging clinical scenarios. And maternal resuscitation is an acute event that involves many subspecialties and healthcare providers. Although most of the features of resuscitation are similar to that of the standard adult resuscitation, but several aspects and considerations are uniquely different. And givers must have a thorough understanding of maternal mortality and maternal near miss to best prevent and treat cardiac arrest. To accomplish a fast response is challenging in patient care areas which rarely witness cardiac arrest, including obstetric units. And hence, it is essential to train and impart knowledge to all the caregivers so that they understand and perform the basic and advanced life support in pregnant patients. And the importance and of specific adaptations or modifications of CPR, which is required for maternal resuscitation. The importance of early, high quality, effective airway and breathing interventions, and the need to perform unique maneuvers like the manual left uterine displacement and perimortem cesarean delivery, in particularly in this group of patients. Today, I shall be addressing all the important features related to maternal arrest, including maternal physiology, the pre-event planning of critically ill pregnant patients, risk stratification during pregnancy, and management of these unstable pregnant patients, and administration of basic life support and advanced cardiac life support in pregnancy. Fetal development and maternal maintenance of pregnancy requires multi-organ physiological adaptations that are pertinent to the team responding to CPR during pregnancy. These anatomical and physiological changes are the pertinent reasons why we have to modify our CPR maneuvers in maternal resuscitation. Pregnant patients who become critically ill, the maternal physiological changes are most profoundly seen in the cardiovascular system with an increase in cardiac output, which is a direct result of increased stroke volume and also to a lesser extent by the increase in the maternal heart rate. The presence of endogenous vasodilators like progesterone, estrogen, and nitrous oxide decrease the systemic vascular resistance, which in turn decreases the maternal mean arterial pressure, reaching a nadir by 20 weeks by the second trimester of pregnancy. The uterine placental blood flow increases from 50 to almost 1000 ml per minute during the term pregnancy. Overall, the uterine vascular reactivity is altered. To maintain the uteroplacental blood flow, there is reduced tone, enhanced vasodilatation, and blunted vasoconstrictions. So, in an event of systemic hypotension, this can overwhelm these compensatory mechanisms which maintain the uteroplacental blood flow. The effect of enlarged uterus on the maternal physiology is profound. The weight of the gravid uterus presses upon the maternal vessels, causing aortocaval compression. The compression on the aorta increases the afterload, and the compression on the vena cava decreases the venous return. The effect of this enlarged uterus starts as early as 12 to 14 weeks of gestation. As the weight of the uterus increases, this aortocaval compression also increases. Poor venous return compromises the infradiaphragmatic intravenous sites. Hence, the sites like femoral and saphenous veins are not recommended for resuscitation purpose. And the supine position in a pregnant patient can lead to hypotension because of the effect of aortic caval compression and the hemodynamic disadvantages. The enlarged uterus elevates the diaphragm and decreases the functional residual capacity by 10 to 25% during pregnancy. The presence of elevated progesterone level stimulates ventilation, and the increases the ventilation to almost 20 to 40% of the baseline at term. The increased ventilation is both increase in the tidal volume and the increase in the minute ventilation. Pregnancy results in an increased oxygen consumption, both to meet the demands of the fetus and the increased maternal metabolic process. Again, the oxyhemoglobin dissociation curve is shifted to the right in the mother, requiring a higher partial pressure of oxygen to have the same same oxygen saturation, whereas it is shifted to left in the fetus, making it relatively more resilient to hypoxic conditions. The upper airway edema and increased mucosal friability, which is associated with pregnancy, increases the risk of bleeding whenever we attempt any airway maneuver. And this also impairs the visualization with laryngoscopy, making the overall airway a difficult airway to manage. The low functional residual capacity reservoir and the increased oxygen consumption leads to a rapid development of hypoxia. So these group of patients have a propensity to develop hypoxia in the response to hypoventilation and apnea. Hence, we have to give early attention to airway and ventilation during our resuscitation. Progesterone delays gastric emptying and relaxes the gastroesophageal sphincter and increases the incidences of aspiration. However, maneuvers to prevent aspiration like tricot pressure are not recommended during resuscitation because they hamper and obstruct ventilation during our resuscitative maneuvers. There's the increase in renal blood flow and in glomerular filtration rate during pregnancy, and there is an altered tubular function to prevent the loss of maternal protein, amino acids, and glucose. But this increases the tendency for pulmonary edema to set up in a critically ill pregnant patient. Every hospital dealing with pregnant patient must be prepared with a pre-event planning, and they should have a proper pre-event planning, including proper training and preparing the caregivers for maternal cardiac arrest and neonatal resuscitation. Severity of illness should be risk stratified. Pregnant patients who become critically ill should be risk stratified by the use of validated obstetric early warning scores, and these patients should be monitored using these early warning scores. Early recognition of critically ill patient goes a long way in prevention and management of cardiac arrest. Once these patients are recognized, this critically ill patients, this unstable pregnant patient must be managed and monitored continuously. The patient should be placed in a fully left lateral decubitus position to relieve them of aortocaval compression. And the 100% oxygen should be administered by face mask to prevent and treat hypoxia. Intravenous access should be established above the diaphragm to ensure that the intravenously administered therapy is not obstructed by the gravid uterus. And the precipitating factors and reversible causes should be investigated and addressed. So, coming to the modifications in our CPR technique, the most important strategy is to improve the quality of CPR is positioning the patient correctly. The supine position is actually recommended for resuscitation because we can be able to give high quality chest compression. But in pregnancy, however, it comes with an added disadvantage of aortocaval compression, compromising the resuscitative efforts. The magnetic resonance imaging studies comparing maternal hemodynamics in the left lateral position and supine position have shown that there is significant increase in ejection fraction and cardiac and stroke volume and cardiac output in the left lateral position. Hence, supine position, which is most favorable for resuscitation, can lead to hypotension in case of a pregnant lady. The disadvantage of supine position, which is aortocaval compression, can however be relieved by two special maneuvers, that is by a manual left uterine displacement and by a left lateral tilt. The left lateral tilt has classically been described to relieve the aortocaval compression. This position is not suitable for CPR because the chest compression force delivered decreases with an increase in angle of tilt, making the chest compression significantly less effective. But manual, on the other hand, the manual left uterine displacement is a very simple procedure, and it is a recommended maneuver during maternal resuscitation. It successfully allows relief of the aortocaval compress while allowing the caregivers to provide good quality CPR so that there is no hindrance to airway management or prompt defibrillation if indicated. This can be performed standing on either side of the patient. If you're standing on the right of the patient, we have to push the uterus upwards and leftwards of the maternal vessel. While standing on the left of the patient, the uterus has to be cupped with both the hands, held by both the hands and lifted upwards and leftwards. And we should take care that we do not push the uterus downwards because this would further compromise the venocaval compression. So continuous manual left uterine displacement should be performed on all pregnant women who are in cardiac arrest and in whom the uterus is palpated at or above the umbilicus to relieve the aortocaval compression during resuscitation. Defibrillation requirement, the energy requirement for defibrillation remains the same as in non-pregnant patients because the transthoracic impedance remains same. It is considered safe in all stages of pregnancy, and the presence of fetal monitors should not deter the care providers to use a rapid defibrillation if indicated. We have already discussed that pregnant patients have a propensity to develop very early hypoxemia, and hence the importance of rapid, high quality, effective airway and breathing interventions are essential during our resuscitative efforts. Although delayed intubation and uninterrupted chest compression are associated with better outcome in cardiac arrest patients due to ventricular fibrillation, it may not be the case with pregnancy because these subgroup of patients have a propensity to develop hypoxia very early. So this necessitates the need for rapid, high quality, effective airway and breathing interventions. As early as 2010, the guidelines have always recommended that for cardiac arrest in pregnancy, the importance of early bag and mask ventilation. A two-handed bag and mask ventilation is a preferred technique using 100% oxygen flowing at the bag at the rate of around 15 liters per minute. And we must address as early as possible to a definitive airway and ventilation. Every hospital should have a maternal code team and a universal code call to activate this maternal code team. And to achieve all the tasks of basic life support, a minimum of 4 responders are required. The advanced cardiac life support is performed by a multiple subspecialty teams acting in coordination, simultaneously addressing 2 critically ill patients. And every team has a well-defined role and they have to carry it out in a well-coordinated and a well-executed manner to achieve a successful outcome. Perimortem cesarean delivery is another unique feature of resuscitation, maternal resuscitation. It is defined as the birth of a fetus after maternal cardiac arrest, most commonly during resuscitation. Perimortem cesarean delivery is the definitive means to achieve complete relief of aorta caval compression and is a part of the resuscitation process whenever applicable, and also as a treatment option during or advanced cardiac life support. The purpose of perimortem cardiac delivery is for both the maternal and the fetus to facilitate maternal resuscitation and also to decrease the risk of permanent neurological damage of a fetus if it is viable.
Any issue, Dr. Anvisha?
Sorry. The timing of perimortem cesarean delivery should be timed to be performed within 5 minutes of arrest. It is performed at it is recommended to be performed at 4 minutes of cardiac arrest in with unsuccessful uh, resuscitation in a mother where we have failed to achieve ROS in a pregnant patient, and the delivery should be effected within 5 minutes after failed resuscitative efforts. It can be considered earlier if we have obvious non-survivable maternal injury or an witness case, arrest case, where prolonged period of pulselessness is suspected, and the survival of maternal survival is chances are bleak. Coming to a quickly about the technique involved, it should be kept simple and it has to be performed at the site of the resuscitation, and no time should be wasted for transportation of the patient to an operation theater or proper abdominal preparations or for complicated surgical equipments to arrive. The decision of incision it depends again on the discretion of the physician. Classically, the vertical incision has been described, but again, it is the discretion of the physician with whatever incision they're comfortable. The fetus, once delivered, if viable, is handed over to the neonatal team for resuscitation. The placenta is once delivered, the uterus is quickly cleaned, and the uterine incision is just closed by a running locking stitch using an absorbable suture. But only when if ROS return of spontaneous circulation is achieved, then we can think of administrating antibiotics and oxytocin, which again we have to be cautious use of oxytocin because it can cause rearrest again in the patient. Coming to the basic life support algorithm, as we've discussed earlier, at least minimum 3 additional staff members are required for administering all the tasks of basic life support. Rest of the algorithm remains almost same as that of a non-pregnant patient, except that the performance of a continuous manual left uterine displacement has to be done continuously by a caregiver as early as possible, and to perform appropriate airway management. The two-hand technique for bag and mask ventilation is the preferred technique. The unique physiology of pregnancy renders a patient vulnerable to hypoxia and hemodynamic disadvantage. And this leads to rapid development of desaturation and apnea in maternal cardiac arrest. The initial resuscitation measures should be done simultaneously: replacement of a backboard, chest compressions, manual left uterine displacement, airway management, and defibrillation as appropriate. Hence, we need a minimum of 4 BLS responders to execute all these tasks simultaneously. The ACLS algorithm is almost the management involves multi subspecialties like the maternal intervention for the obstructive intervention and a neonatal team for the neonatal intervention. The maternal intervention team, they should consider airway to be difficult, and hence the most experienced providers should be preferred to provide the manage the airway, and a intravenous line should be established above the diaphragm. If the patient is receiving magnesium, that should be stopped, and calcium chloride 10 ml of 10% solution, or calcium gluconate 30 ml of 10% solution should be administered. The obstetric team should manage a continuous manual left uterine displacement and prepare for emergency cesarean delivery. If no ROS is achieved by 4 minutes of resuscitative efforts, then they should perform an immediate emergency cesarean delivery at the site and hand over the fetus to the neonatal team for resuscitation. As the airway is considered difficult, the most experienced provider is preferred to attempt intubation, and early intubation should be attempted, but only 2 attempts should be done, so that we do not cause much airway injury and we can avoid trauma. If we fail to intubate, you should go for a supraglottic airway device. A supraglottic airway device with an esophageal drain is a preferred device. And after 2 attempts at supraglottic airway device, we can straight away go back to mask ventilation. And if even mask ventilation is inadequate, we reach a situation of cannot intubate, cannot ventilate, then we should attempt a percutaneous cricothyroidectomy. And as in consideration of the airway edema and difficult airway, it is recommended to use smaller size endotracheal tubes. And we can use a shorter handle blades, laryngoscopic blade, to aid in our airway management. Successful resuscitation of a mother and survival of the fetus requires appropriate modification and prompt and high quality CPR. Associated aortocaval compression and propensity for hypoxia should be addressed, and early intubation and protection of vulnerable airway with IV access above the diaphragm is recommended PMDC as and when recommended. Knowledge deficit and poor resuscitation skills are major contributors to poor outcomes, and this further justify the appropriate training and preparation for such events despite their rarity. Thank you.
Thank you, madam. Very nice presentation. Dr. Vijayalakshmi, can we move to the next speaker?
Sir, we have a couple of questions in the chat box, sir.
Yeah. We'll take
What
a
about
minute.
outside hospital arrest? One of them had asked. Yeah, we'll quickly finish a couple of things and go to the next session, sir, in 2 minutes probably. So one of the speakers has,
Please.
sir.
Can you answer the question? The question, how do you
Dr.
do it?
Anvisha, it's a question about outside hospital arrest. Sir,
Yeah.
I'll
For
read it out.
outside hospital arrest, we can continue our all the resuscitative efforts, including manual left uterine displacement, except the perimortem cardiac cesarean delivery, because this has to be performed at a hospital unit which has the capacity to conduct a cesarean delivery. So this patient has to be transported to a facility which deals with obstetric deliveries.
After the arrest in pregnant, when you do cesarean section, any special guidelines?
Yeah, it has to be done as early as possible, because out of the hospital, patient has to reach a hospital a facility which can conduct a delivery. So even if we should try to reach the patient to a hospital unit within 10 minutes. That is what is recommended. But even if it is delayed, we can still go for a PMCD after reaching the hospital, any hospital unit. But meanwhile, we can do the manual left uterine displacement to relieve the aortocaval compression and continue the rest of the CPR guide techniques.
Where should the person stand for doing LUD?
It can be done from both the sides. Like if it should be done as early as possible. Even if a person stands on the left or the right, it doesn't matter. If just the maneuver matters. If you're standing on the right, you have to just push it upwards and towards the left. And you're standing on the left, you have to just hold the uterus or cup it with both your hands and pull it towards yourself and upwards. So it can be performed on either side. Again, it is the decision of the team which is performing the CPR. But it is described to be performed on both the sides.
There are only 3 questions are there. Only 3 questions are there. We can move to. You want to add up to it? Okay,
in hospital cardiac arrest, we have to do this planned cesarean section if the patient does not achieve a ROS within 4 minutes of resuscitation. 4 minutes of unsuccessful resuscitation, we need to start preparing the patient for an emergency cesarean section.
Thank you, madam.
So are we ending this session, sir? Janand, sir, any further questions?
Dr. Sumana wants to add up anything? She's not there. Okay, thank you. Thank you, Vijayalakshmi.
Thank you very much, sir. So at the end of that session, I think we'll thank you both chairpersons, Vijayan sir and Sumanlata madam. Thank you very much. And thank you, Anvesha Swain, Dr. Thank you very much. So as we move on to the next session, which is whatever we are seeing now, COVID season. So regarding that, we'll I think you're able to see my screen.
No, madam.
No, yeah. Just a second. I'm just sharing my screen.
Sure.
Oh. So we move to the next session. Which is COVID and CPR. So to chair this session, we have 2 eminent faculties. Now you're able to see my screen, sir?
Yes.
Yes,
Great.
okay. Dr. Pankaj Kundra, sir, he's already there. So he's Professor, Senior Scale, Dean Academics, Department of Anesthesiology Critical Care, JIPMER, Puducherry. His achievements numerous. He's put it very short. ISA Lifetime Achievement Award, Orations 9. He's the President-elect of AIDA. Publications about 131 peer-reviewed and counting. And areas of interest include airway and intensive care. Welcome you, sir, to this session. And for the next person who's chairing this session is Dr. Chandrakant Patel. He's the Additional Chief Medical Director, Technical and Administration, Western Railway Headquarter Office, Mumbai, Jagjeevan Ram Hospital, Mumbai, with achievements of his Joint Secretary, National Indian Railway Medical Services Association, ex-GC member of RSACP, Honorable Secretary, Railway Association of ISA. Achievements are oration on CPR 2020 guidelines recently at Railway Association of ISA. He's also received the Western Railway General Managers Award for Meritorious Service in 2014 for awareness and hands-on training, CPR for doctors, and delivered various talks and presented papers, and had numerous best paper awards in 2007, 8 and 2015. His areas of interest are CPR training, regional anesthesia, and pain management. So over to the
Thank you.
chairpersons to introduce the speaker. Welcome, sir.
Okay, I take the pleasure
sir.
and honor to introduce Dr. Sai Saran. Thank you very much, Research Society of Anesthesiology and Clinical Pharmacology, for giving me this opportunity to be here and be amongst all the delegates and chairpersons and speakers. It's always a delight to learn from everyone. And I think the next speaker is no less than a very learned fellow. He's done his MD and from Jipmer Pondicherry. Thereafter, he has joined. He has done his DM in critical care from SGPGI, and he was selected as the best DM resident in 2017 at SGPGI. Currently, he's working as an assistant professor at Super Specialty Cancer Institute and Hospital. He's in charge of the RML COVID ICU. He has 30 publications, and his main areas of interests are prone ventilation, hemodynamics, and advanced modes of ventilation. It's a pleasure to listen to you, Dr. Sai. Over to you.
Sir, and I hope I am audible. Yeah.
Yes, you're audible.
Good evening, sir. Yeah.
Actually, you mute everybody and then let him unmute himself.
Hello.
Yes.
Yeah.
I'm muting all.
I think.
Yeah, Dr. Sai, you unmute yourself. I mute everybody. Yes. Unmute yourself, Dr. Sai.
Yes. Good evening, sir, and good evening, everybody. It's my pleasure, and when I hear some words from my teachers, and I feel extremely delighted. And it's very cold here, as previously one of the speakers has said, and it's very tense because I am presenting about CPR in front of the great dignitaries who had created and made guidelines of Indian resuscitation guidelines for the management of critically ill or cardiac arrest patients, especially diagnosed with COVID-19. I hope I'll be able to provoke some thought process by the end of my lecture, which I wanted to for the purpose of this talk. So I want the objectives of the talk, like it contextualizes CPR in COVID, what modifications we need to do in out-of-hospital cardiac arrest, what modifications are required in in-hospital cardiac arrest, what are all the current outcomes of CPR in COVID, what are the myths behind the respiratory protection of a healthcare worker. There are various guidelines. Which ones to stress? Definitely, all guidelines have their own plus points, and they were made by eminents, including the Indian resuscitation guidelines, which were there. I tried to go through all these guidelines, and I will be incorporating the key nutshell or the important points which are obtained from all these guidelines. First of all, I want to start with that loss of a healthcare worker can be a triple threat. We should always think about saving ourselves. To date, as on September 20, which is a previous date, like around 7,000 healthcare workers died. And as said by the president of Indian Medical Association, around 515 doctors probably treating COVID patients have sacrificed their lives. So loss of a healthcare worker or any healthcare is a triple threat to the society. One, is a asset or boon to the system. When I also got infected, I was away from the duty from last 14 days. Next, he will be a burden to the system. And next, he can spread the infection, as we know. So it is a triple threat. Outcomes of CPR, especially in COVID, till now are very poor. I don't know. I am not telling that we should not do CPR. We should do, but we should take care of ourselves. Coming to out-of-hospital cardiac arrest. As we know that first we alert the emergency and then we cover our own face, especially with whatever device we have, like whatever mask you are having, and cover the mouth or the nostrils of the patient or the person who is lying over there. Start performing hands only CPR. And if AED is available, I mean, Indian scenario, AED, especially in malls and such places, it is available, but rest of the places it is very difficult. Then you call for advanced resuscitation, post cardiac arrest care. And as we know that the another link which is being added or updated by the latest guidelines in 2020 is the recovery. So let us use our common sense. Tighten the mask which we are having, whatever we are. And although guidelines say that surgical mask or FFP2 is its equivalent is okay when you are doing a non-aerosol generating procedure. In community, it is very difficult that a patient can or a person can be moving around holding a surgical mask, but a healthcare worker who knows how to do CPR will definitely moving around with a mask which is able to protect him from non-aerosol generating procedure. Simultaneously, you can alert the ambulance services, cover the face of the victim as previously shown, and start chest compressions. Then you can wash your hands with soap or water or alcohol-based hand gel after the procedure. Till date, chest compressions or defibrillation has no 100% proof or high evidence supportive that these are aerosol generating maneuvers. So what does the in-hospital cardiac arrest? Okay, we are now equipped with the equipment. We can don PPE, whatever we have. The next thing is you should limit the personnel who can enter the room. Consideration for mechanical CPR devices which are very scarcely available in majority of the hospitals. And of course, clear communication among the team members that this patient is suspected COVID positive. So the entire team who is resuscitating is aware of various closed loop communication which is frequently discussed in the cardiopulmonary resuscitation. So as we know that respiratory arrest is the most common especially when you are dealing with COVID. Prioritize the oxygenation and ventilation strategies with lower aerosolization rate. You can use HEPA filter for all modes of ventilation which you are having. Create a bag mask ventilation with HEPA with a tight seal. Intubate. Consider the expert who has donned adequate PPE, who can intubate this patient electively or emergently and with a high success rate. That is, I mean to say that expertise is needed. Pause chest compressions during intubation. Video laryngoscopy, if available, is definitely helpful, as we all know. For a short duration, if airway cannot be secured, you can do passive oxygenation, connect him to a face mask, connect him to nasal cannula, and then you continue your chest compression. If intubation is delayed to any reason, second generation supraglottic airway device can be considered as recommended by the IRC guidelines. And always ensure that there is closed circuit. Anywhere there is no aerosol spillage or aerosol leakage. Of course, you should know the goals of care on whom you are doing this activity, as I had already stressed that it will be a triple threat if any one of the healthcare worker gets infectious. So you should clearly address the goals of care, how long, how much time, and this patient, whether he definitely requires cardiopulmonary resuscitation according to his clinical scenario at admission. Various suggestions have been proposed by experts like Professor Kundra suggesting that a clear transparent sheet can be placed over the patient and chest compression. This is an excellent thing, like whatever mask you are wearing, especially this is very useful in out of hospital cardiac arrest also. Tighten it, ensure that there is a tight seal, as we know that this is a 3-ply mask. Once you enclose or close all of your airway where the risk of aerosolization can be there, the chances of infection to you can definitely come down. Apart from that, a clear transparent drape can minimize. This has been suggested by even experts all over the world. Mechanical CPR devices. These are a need of the hour because with PPE, a person doing chest compression, I did on 2 to 3 patients. It is not so easy. It is not so easy. It is easy to say that you do at 120 beats, 120 compression per minute. It is extremely fatigue. You need to rotate the compressor so frequently. Even then, with double gloves and N95 fitted on with so many gadgets around me, the impact, even the systematic review evidence also suggests that the chest compression effectiveness comes down when you are donning a PPE and you are doing it. So mechanical compression devices are required in such conditions. They're definitely useful because the manpower which is for the chest compression will be diverted, and even the healthcare worker can be protected with the use of mechanical compression devices. So these are the modifications. As we know that we need to don the PPE, we limit the personnel, do not listen or feel, don't go near the oral cavity or the airway of the patient. So if there is no breathing, you start providing bag mask device with a filter or a tight seal, as you can hold it with 2 hands, create a tight seal, place a filter even in the ambu bag or the manual resuscitator which you use, and look for rest of the algorithm almost remains the same. The entire algorithm stresses on that minimization of the aerosol risk or the protection of the healthcare worker, which is needed. Now you start chest compressions. Again, you use a bag mask with a tight seal by 2-hand technique, or you use continuous compression with a passive oxygenation. I had included a 2nd generation LMA device, especially when an expert is available. Why to take that minimal risk of bag mask ventilation also? You can insert a supraglottic airway device in order to protect this, although this is not basic life support. Definitely, these can be considered quite early in order to minimize the aerosolization which can happen in such patients. ACLS, again, you have to same concept runs on. The early intubation is definite role here, as we know that aerosols are the thing which can create problems to all the healthcare workers. So minimize the subacute disconnections which can happen. Again, an intubator who is experienced and trained, and consideration of video laryngoscopy could be done. Indian resuscitation guidelines definitely mentions that if a shockable rhythm is there, any guideline mentions, and if a shockable rhythm is there, you definitely defibrillate. The only shockable rhythm, majority of the times, which can be encountered, which I have seen in the last 6 months of COVID management, is one case of hydroxychloroquine, let it be so many drugs which we don't know. Almost a patient is receiving 6 to 8 drugs which can prolong QTC, so that should be definitely considered in such patients. Of course, a 6th H like hypomagnesemia or hydroxychloroquine induced QT prolongation can be considered, although it is not stressed in it. And again, defibrillation can be replaced by using a paddle-free defibrillator, provided the adequate chest space is given for chest compressions. So rest of the guidelines stress that you can pause the chest compression, especially when you are doing intubation. If intubation is delayed, you can consider supraglottic airway and minimization of aerosol risk. IRC guidelines also stresses in the similar manner, donning the PPE, responsiveness. When he is non-responsive, you activate the code blue, get the crash cot, and the breathing. And the clinical scenario is classified into 4 conditions here, that the patient is normal breathing with definite cardiac pulse, abnormal or no breathing with definite cardiac pulse. There definitely we will secure an airway, give a breath, 1 breath every 5 to 6 seconds. Abnormal or no breathing without a pulse, we start chest compressions in 30:2 ratio. Patient on ventilator without a definite cardiac pulse or perfusing rhythm, now you turn the patient supine. Especially, I think this is if it is the patient is prone. I don't go into this area as it is a second topic which is being considered. And we continue 5 cycles of chest compressions. This sort of classification was not available in the rest of the guidelines, like consideration into 4 clinical scenarios, and early defibrillation has been stressed here, and rest of the guidelines almost are similar, resembling the other resuscitation guidelines. Definitely useful, and they appreciate the clinical scenario, they understand and they communication wise very good. So what are the various innovations which were there? Like we mean to say that a preloaded endotracheal tube on a video laryngoscope with a HME filter or HEPA filter connected, definitely useful. And a swivel adapter which is connected. So many innovations were there. Like in few scenarios, like where primary health center, community health center, there might not have been the availability of a video laryngoscope. You can just at least protect the healthcare worker. There might not be having availability or access to even PPE kits. So in such cases, when emergency intubation needs to be done, you can just block the endotracheal tube and come away from the space and then disconnect it, attach it back, and then you can do continuing your chest compressions. So what does the largest study till date says? This is states around 5,000 patients for whom cardiac arrest or critically ill patients who got admitted across various states of United States, around 68 intensive care units, 5,000 patients admitted, around 14% had cardiac arrest, and around 58.3%, around 28 patients were discharged with normal. This is the largest study till date which assessed in particular to cardiac arrest with COVID-19. The important implications which we can learn from this: the number one, it is respiratory failure or prothrombotic condition which is leading to death. Majority of the cardiac arrests are non-cardiac, and rhythm in majority of the cases were pulseless electrical activity or asystole. Why this is important is that one, we knew that we will be able to understand that the rhythm majority of the times might not require defibrillation. I think the experts in the group can discuss. We have seen a lot of cases with respiratory acidosis with hyperkalemia in the last 6 months of management of COVID-19 critically ill patients, but the patients requiring defibrillation, according to me, were less. The experts in the group can comment upon later on that the rhythm in majority of the cases is asystole requiring continuous chest compressions. Another study again proving the fact that it is majority of the times pulseless electrical activity or asystole rather than a defibrillating rhythm or a perfusing rhythm which is there. Ongoing organ supports in intensive care unit, the patient is already on resuscitation, already on high organ supports. The first thing you should do is any reversible cause, if it is there, definitely we will do, like ventilator disconnection, improper alarm settings. It is not anesthesiologist or it is not the intensivist who is there round the clock managing intensive care units now in India, especially in pandemic. Improper alarm ventilator settings, disconnections, low tidal volume generation, low minute ventilation generation. These are the reasons where we had probably triggered out and disconnections of the ventilator circuit. We lost patients, and these are the things which should need to be ruled out when organ supports are going on. So the goal in this scenario is most important is to prevent cardiac arrest rather than do chest compressions, as we have seen that does he fit into DNA CPR? That also needs to be discussed. Early recognition of acid abnormalities. At-risk patients, especially if ward settings are there, like you can at least shift them to a isolation room. As we know, the scarcity of negative pressure isolation rooms, at least you can shift him to a private room where you can anticipate that this patient might have cardiac arrest with adequate monitoring, with telemonitoring facility, and thereby you can protect the healthcare workers. This is what I mean to say, like a patient, although this is a clipping which is taken from a YouTube, this is the resuscitation room. A patient whom you identified in the hospital with suspected COVID, you can at least keep her or in a room where resuscitation can take place. That is called a hot zone, and a warm zone where assistance for resuscitation can be provided into the closed room. Thereby, one, you can minimize the aerosol generation to all the staff. And number two, you can divert your energy and resources to various other aspects. Practically difficult, but especially this is applicable in patients like we don't have a single isolation cubicles in intensive care unit in majority of the ICUs. Like that, ward with a private isolation room is definitely useful where healthcare worker can be protected from this. These are the various dreams of CPR, definitely appreciable, like all the ventilator consoles, infusion pumps, external cardiac compression devices were placed to the patient, and CPR can go from even outside the ICU cubicle. This is the future, probably, like the ventilator console is separated, Hamilton, inside the rest of the aspects are there. Infusion pumps are attached outside, adrenaline can go place, a mechanical CPR device is attached, defibrillator paddles are attached to the patient. Yes, continue the chest compression, continue the CPR for how much duration is possible. requires a lot of cost, a lot of expectations, but definitely it is possible. So to date, more data is required to comment whether CPR is absolutely necessary in such patients. I am not saying that we should not do it, but guidance from professional societies and biomedical ethicists is definitely required when to perform cardiopulmonary resuscitation, and how long should I do it? Am I protected well? And how to do it? Panel in front of me, definitely you can tell me that 100 to 120 per minute doing chest compressions is not an easy task. To rotate compressor 1 to 2 minutes, definitely we don't have such manpower clinically we are facing with. Mechanical CPR devices in majority of the hospitals, hardly we can find 1 or 2, and very few hospitals have them. Push hard, push fast, 100 to 120. Why not 90? Why not 95 when we are wearing a PPE kit? Are we protected from aerosols? Are we 100% protected from this? N95 mask which I am wearing, does one size fit to all? Scarcity of negative pressure rooms and efficient HVAC systems in majority of the ICUs or majority of the resuscitation zones is another issue which needs to be addressed. A huge gap in scientific literature. Yes, previously it was 60, later on increased to 100, later on 120. Animal studies show that when you do compressions at a higher rate, the blood flow increases. 2 human studies compared that 80 versus 120. 120 is better, the ROSC or the blood flow is better and perfusion is better. The guidelines started recommending that 120 is the recommended rate. But none of these studies observed the return of spontaneous circulation and on human beings. So I am not asking that, I am not questioning the efficacy because these were prepared by highly intellectual people above me, but why not 95 when we are wearing a PPE? That is my question. As we know, the respirators, we have 2 types. We don't want air supplying respirators, which are used as SCBA. What about air purifying? We have powered and non-powered. What we are generally using is a non-powered respirator, which develops a negative pressure inside the device upon inhalation. What about powered respirator? It has an extrinsic part. It has air purifying element. It has positive pressure inside that. It is providing 100% pressure to the healthcare worker. Are we protected really? The tested, they offer resistance when inhalation. They offer resistance while exhalation. At max, we are doing what is called as seal check, where the healthcare worker covers it around the nasal cavity and the oral cavity. You apply tapes to him. What about fit test, quantitative fit test, which is recommended for all the healthcare workers before they don it? My face today might not be my face once I became obese, or once I lose weight, or once something happens to my face. The N95 which we is prescribing to all size of healthcare workers is not the correct one. And the movement of the body, like when you are doing chest compressions, especially quantitative fit test, the various positions, up, down, left, right, a porta count device will be in, particles will be bombarded and they will be ensuring whether the N95 is fitting to you. You can see the evidence also that when a person is doing CPR, his exercise or his expiratory rate is definitely more than 95. So where can the air which is surrounding by COVID-19 is being inhaled to the healthcare worker? When you're doing treadmill itself, the peak flow rate can reach around 400. When you are doing exhaustive cardiopulmonary resuscitation, what will be your peak expiratory flow rate? And one size does not fit all. Around 28%, this is an observational study, 28% healthcare workers did not fit into any of the 3M, whatever company respirators which are there. So in front of the Indian Resuscitation Council guidelines, I request that the government of India should be requested that healthcare worker needs a minimum of a powered air purifier respirator. Filtering respirators offer negative pressure, high resistance, especially in high work intensities. Especially anesthesiologists and the intensivist, whatever. We are the main health force or workforce who ran the COVID-19 show entire India. So we require resuscitators or respirators, which are PAPR. So to conclude, ease of access to N95, eye protection, caps. You should limit the healthcare workers or the number of personnel. External chest compression devices are a must. They are needful. We need them. Clear plastic sheets can be useful. Covered with HEPA filters. Immediate intubation or early securement of airway is the major difference, along with minimization of the aerosols. Telemedicine in high risk patients, and physician ordered life sustaining therapies for how much time, how long, and consideration for palliative care consultation should also be there. I sincerely thank the committee for giving me opportunity, and I apologize if did not meet your expectations. Thank you.
Thank you, Dr. Sai, for a very well-researched this talk. I think everybody would get benefited from this research talk, I would say, because a lot of new things we have seen, which usually we don't see in a single article. So many congratulations for this, for a nice presentation. Now I will request Dr. Kundra sir to say, take the proceedings further, sir, because there are some questions also, sir, that we can take if time permits, sir.
Dr. Sai, a very lucid presentation. We could, I mean, very nice to learn things with the perception of you working in COVID ICU for past 6 to 8 months. There are a few questions which have been put up. The first question which is there is that the use of supraglottic airway devices, because most of these COVID patients would have ARDS and the airway pressures are going to be very high. How far that soft seal of a supraglottic airway device is going to work?
Dr. Sai, I hope you are listening.
Yeah, I am listening, sir. I am listening.
Please.
I am just definitely supraglottic airway devices. If in emergent situation, when you are not able to intubate or when expertise is not there, you can consider. But ventilating through supraglottic airway device, I think it is very difficult. But we had faced scenarios of cannot ventilate, especially the second generation supraglottic airway device like IGEL had saved 1 to 2 lives, definitely, which we can say. They cannot match the peak airway pressures which are there in the ARDS, which based on my experience, which I've seen limited experience, definitely ventilation through this for a long period is not possible. You can put them, and we did tracheostomy. Once we secured the airway through iGel or ProSeal, we opted for percutaneous tracheostomy, and we could do it. Anything, sir?
Yeah, there is another, someone has put Arun Kumar. How frequently do we need to change the filtering resuscitators? What is that question is not very clear to me also, but if you can get or about this, how frequently do we need to change the filtering resuscitators? Can you get the question? I am not able to get, sorry for that.
And, no, sir, I couldn't hear, sir. I couldn't hear.
Okay, no
yes,
issue.
Sir, please,
yeah.
Sir.
How frequently do we need to change the filtering resuscitators? Yeah, that is the single line, the query from our audience.
Filtering resuscitators means the N95 mask which is talking, or the HMEF?
Yeah, that is not clear. That's why I was also not very clear.
HMEF, if it is HMEF, it is like we have to wait for soiling or any obstruction or any blockage, then only it is recommended to change. But usually we change it every 48 to 72 hours. If properly maintained, they can function very well. And regarding N95, definitely it is only single use, especially when you use in intensive care units. I don't recommend to reuse them because it loses the configuration and drying up in sun. This is all for community. once you are doing a procedure of aerosol generation, single use.
Yeah, definitely. Yeah, so I think there is no other question. If the time permits, Dr. Vijay Lakshmi, can we take from the audience, or we can take the proceedings further for the next session?
Sir,
Dr. Vijay Lakshmi, please.
Yes, sir. We'll proceed further. We can
Great.
take
Thank you.
questions at the end in the open house.
Thank you.
Thank you, sir. Dr. Sai, you can stop sharing your screen, please.
Yeah, thank you.
I thank both the chairpersons, Dr. Kundra sir and Chandrakant Patel sir.
Thank you very much.
Any other insight from you?
Just one comment which I wanted to make was that, yes, initially we do not see such shockable rhythms, but when you do the CPR and when you start giving epinephrine, you may actually land up with a shockable rhythm. So it's always better to be prepared with a defibrillator, which you may need subsequently once you are giving or performing the resuscitation maneuver. I mean, that's all I would like to add to what Dr. Sai has already mentioned. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, ma'am.
Both chairpersons, Dr. Pankaj Kundra sir and Chandrakant Patel sir. And
thanks a lot. Thanks a lot.
Sai Sharan, excellent presentation as always. We've seen you. So can you stop sharing your screen? Yeah, thank you. So we move to the third session, which is prone position in CPR. So let me introduce the chairpersons for this session. The first chairperson we have is a person from IRC, Dr. S.S.C. Chakrarao sir. I hope my screen is visible. Is my screen visible?
Visible.
So Chakrarao sir is the chairman of Indian Resuscitation Council. His achievements are numerous. He's a member of the Constitutional Committee, WFSA, past president ISA 2014, past secretary ISA 2008 to 2011, founder of the Family Benevolent Fund. He was the former additional director of Medical Health Services AP, recipient of Red Cross Medal from Governor, gold medals twice as Best State Branch Secretary, awarded twice as Best in NRHM Project, and awarded gold medal by the Governor of AP working for membership drive in Indian Red Cross Society. Best Performance Prize twice as BMNHO. International conferences he has attended, presented papers and bid for ISA conference. And he was an invited guest faculty at various international conferences at Malaysia, Hong Kong. And he's also a member of Constitutional Committee of WFSA. And he is Indian Guidelines of Resuscitation to ISA, brought out the compression-only life support and imparting CPR training free to children and laymen throughout India. So as on 23rd October 2018, he achieved 250,000 CPR trainings as a mark of World Restart Heart Day. So welcome you, sir. To the next chairperson of this session, I would like to introduce my mentor, because of which I'm in anesthesia right now, Dr. U. Srilakshmi Madam. She's the consultant anesthesia and critical care, the chief intensivist of Nagarjuna Hospitals, Vijayawada. Invited faculty at various conferences. It's the first NABH accredited hospital in Central Andhra. Her areas of interest include quality and safety in anesthesia and critical care, pain management, palliative care, and hospital administration. So over to you, Chakrarao sir and Srilakshmi Madam, to introduce the speaker.
Dr. Srilakshmi, you introduce Swati Chavra.
Okay, sir. Vijay Lakshmi, I can't see the screen.
Yes, ma'am. I am just projecting. Yes. Yeah.
Good evening, everyone. Thank you very much, team, for giving me this opportunity to be a participant and a chairperson for this eminent faculty. Dr. Swati Chavra is an associate professor at All India Institute of Medical Sciences, Jodhpur, and she was an invited faculty at various conferences, and she achieved Best Paper Presentation Awards at national and international conferences. She is also an associate editor for the Indian Anesthetists Forum. Her publications include 35 papers and 4 book chapters. Areas of interest are acute pain management and neuroanesthesia. Thank you.
Thank you, ma'am. So,
thank you, ma'am, for the introduction. And I thank RSCP and the organizing committee for this webinar, for letting me present in this esteemed webinar amongst the esteemed faculty we have. And to begin with this, am I audible and are my slides visible?
you're audible and your slides are also visible, Swati.
Yeah, okay. Thank you. And while continuing this CPR series, I'll be presenting now on prone position CPR. So it's a simple overview. We'll be just simply discussing why, when, how, and then we'll just be summarizing the things. First of all, why are we talking about prone position CPR? Because CPR has always conventionally been taught and performed in supine position, but obviously patients can arrest in prone position as well. There is limited literature and evidence for its efficacy, and clear guidelines are not there for prone position CPR. So we are in a fix. And when do we want to perform the prone CPR? We are talking probably about this since resurgence of COVID-19 cases and more patients in prone. But it has got a long history, and it is commonly seen with intraoperative arrests during prone surgeries like spine surgery, neurosurgery, retroperitoneal surgeries like PCNL, etc., and patients undergoing prone mechanical ventilation in ICUs. It has even been described historically in out-of-hospital arrest patients found face down. But societies no longer recommend out-of-hospital resuscitation in prone position. So we are left with just cardiac arrests when the patient is prone, already intubated, being ventilated, and in ICUs. And more and more patients are being seen in prone position these days. So how do we approach a prone patient? So first things first, prophylaxis first, we should prevent any arrest to happen. So we should continue monitoring and recognize pre-arrest signs early on so that arrest is prevented on the first go. Like suppose in a neuro surgical case, if we see there is fall in end-tidal CO2, we should suspect venous air embolism fast, hypotension, or hypovolemia, whatever it is. In major spine surgeries, if there is massive hemorrhage, we should just treat it and avoid a cardiac arrest situation. But if it happens, there should be a system for cardiac compressions. Cardiac compressions should be initiated early on. And we should decide in a high risk patient if the cardiac compression, the thoracic area is draped by the surgeon, then surgeon can start with the cardiac compressions. We can develop a system for that also. And there should be a technique in place for defibrillation. Like in this scenario, we'll be discussing later, self-adhesing defibrillator pads are preferred over paddles. And then obviously we should continue, we should find out the underlying cause of cardiac arrest, and specific management should be targeted towards that underlying cause. Now, why are we resuscitating the patient in prone position? What are the problems with turning the patient supine? Obviously, it will delay the onset of compressions if we turn the patient supine before beginning the compressions. And our Indian Resuscitation Council and has these core links in their CCLS program, the Comprehensive Cardiopulmonary Life Support Program, in which early high quality CPR is advised, and same is with the chain of survival by the AHA. So any delay is hazardous with every second of delay in onset of compressions. Obvious, and also turning the patient supine is time consuming. It requires multiple individuals, mostly 4 to 6 persons. There are chances of endotracheal tube displacement and disconnection of arterial and venous lines. There might be open surgical wounds with ongoing blood loss. There is risk of neural damage due to unstable spine. And for neurosurgeries, for craniotomies, the head could be fixed with pins. So these are all the problems which goes against turning the patient supine. So we start with the CPR in prone position, adjust for the things, prepare for turning the patient supine if it is required. Otherwise, we can safely continue with prone CPR. But how to do the chest compressions in the prone position? What is the optimum technique? There is no recommendation as per the hand placement or defibrillatory pad placement by AHA, IRC, or UK Resuscitation Council, or even the European guidelines are not there. Sun et al. In 1992 had described a technique called reverse precaudal compression. They resuscitated 2 patients successfully in prone position. And quite recently, with COVID-19 pandemic, Faculty of Intensive Care Medicine and Intensive Care Society has recommended a two-handed technique over the mid-thoracic spine between the 2 scapulae. And due to chances of exposure to the aerosols, the use of second person to apply counter pressure is optional in these guidelines. Now, to find out the exact position of hand placement for compressions, this study was conducted in 2017 by Kwon et al. And they conducted CT scans in 100 patients in prone position to identify the vertebral level correlating with the largest left ventricular cross-sectional area as the optimum position for compressions over the back. They concluded that the largest left ventricular cross-sectional area is 0 to 2 vertebral segments below the inferior angle of scapula in at least 86% of patients. But obviously this was a radiological study, and whether this translates into clinical advancement or not requires further studies. So this is on a mannequin, and obviously we can see that our mannequins are also not prepared for training about the prone CPR. So I have drawn the scapulae over the back of the mannequin. So inferior angle corresponds with T7 vertebra, and hand should be two-handed technique. Hand should be placed as depicted in the picture, and another person should place hand or fist beneath the sternum as a counter pressure. And this is the position in the lower figure about the placement of defibrillation pads, one over the right scapula, one in the left axilla. Although biaxillary positioning has been described, and so has been the antero-posterior placement, but that would be difficult in a prone patient to place an anterior electrode without wasting time, and there would be interruptions in the chest compressions. So this is the most ideal setup for defibrillation pads. And when it is an intraoperative arrest, it would be difficult to place defibrillation paddles. So it's good to have these adhesive pads. And after this placement, according to the guidelines by Indian Resuscitation Council, we can continue at the rate described 100 to 120 per minute. And most of the times there is advanced airway placed. So that can go along with continued ventilation with one breath every 6 seconds. And it can continue the drugs can also be continued according to that. And if following the AHA guidelines, their algorithm can be followed after that. The ultimate aim is to reduce the potential time without blood flow, that is the no flow time, through continuous and effective chest compression. So it goes without saying that CPR quality should be optimum. The shock energy for defibrillation and the drug therapy remains the same as in the supine CPR. Now let's review some evidence and do the literature review. So the earliest evidence came from as early as 1989, when McNeil first mentioned the prone CPR, but it was not well taken, and still not much research has been undertaken in last 31 years or so. And in 2001, Brown et al. Presented a case report of successful resuscitation of intraoperative arrest, and a systematic review was conducted. Now, most of the literature was case reports or case series, and they presented mostly were spine surgeries or craniotomies, and one of these patients was for prone ICU ventilation. Out of 22 patients, 11 patients could be resuscitated successfully and discharged from her hospital. But there is always a chance of publication bias that successfully resuscitated patients are more reported and published. Still, we don't know the thing about the efficacy. Then this was a study by Mazur et al. This was a small pilot study of CPR in the prone position, wherein they studied 6 patients who had undergone standard or supine CPR, but they were not resuscitated. There was no return of spontaneous circulation after 30 minutes. So they performed prone CPR for another 15 minutes. And they observed that reverse CPR generated higher mean systolic blood pressures and higher mean arterial pressures during circulatory arrest than standard or supine CPR. But none of these patients could achieve ROSC, or none of them could survive. So we still don't know whether this higher mean SBP and mean arterial pressures were of any clinical importance. And we continue to see such individual case reports in literature till date about successful cardiopulmonary resuscitation in prone patients. Most of them are neurosurgical patients, spine surgery patients, but there is no obviously RCTs, and these are not possible ethically for this subset of patients in examining the role of prone CPR. And because of this reason, probably the guidelines are also lacking any recommendation. So regarding American Heart Association guidelines for prone CPR, in 2010, they mentioned, and I quote, "When patient cannot be placed supine, then it may be reasonable for the rescuers to give CPR in prone position, particularly in hospitalized patients with an advanced airway in place." In 2015 guidelines, this aspect was not reviewed. And in the most recent ones in 2020, they mentioned the efficacy of CPR in prone position is not established, but the very limited evidence suggests that it may be better than providing no CPR when a patient cannot be placed in supine position or until this can be done safely. And it is important to mention that they conducted large formal evidence review in 2010. And as far as training is concerned, in 2014, Toffel et al. Published this study in which they asked the anesthesia residents to perform resuscitation in a simulated prone ventricular fibrillation arrest in anesthetized pediatric patients. And it is quite surprising to note that none of the groups of the anesthesia residents performed chest compressions when the patient was prone. So they started compressions after turning the child supine. So that wasted some precious seconds, and there was a delay in initiation of chest compressions or delivery of defibrillation. So what is the road ahead for prone CPR? It is quite dicey because of lack of evidence and guidelines. So we need better training. We need more research, although we expect better insight with more experience during the COVID-19 pandemic. So to summarize the pluses and minuses of prone CPR, it helps by avoiding delay in initiation of chest compression and defibrillation. And it is important to note that mostly intubated patients are involved with ongoing mechanical ventilation and invasive lines in situ. And it is useful that we can perform prone CPR when it is difficult to turn the patient with open surgical wound. And delivering effective chest compressions may be difficult when the patients are positioned prone with the help of frames, because that pressure is dissipated over the frames and not conducted to the precordium. And it is difficult to hold defibrillator paddles, and there is limited evidence. And it is recommended that the efficacy of CPR should be judged using the end-tidal CO2 and arterial pressure waveform with the patient turned, and the patient should be turned supine if chest compressions are judged to be ineffective. So I'll be summarizing with a video and the algorithm. So this is a demonstration of CPR in prone position in a mannequin in a CPR trainer. So most of the times there is patient is intubated and being mechanically ventilated, and site of placement is at the level of inferior angles of scapula at the level of T7 vertebrae, as we had seen in the evidence also. And the height of the performer who is doing the compressions should be adjusted. Another person should place hand or fist under the sternum and perform the compressions, high quality CPR as per the guidelines at the rate of 100 to 120 per minute, and allow for adequate recoil. Defibrillation pad should be placed without interrupting the chest compressions. One in the over the right scapula, one in the left axilla. If there is a surgical wound like over the spine, so hand placements could be like this with the sternal counter pressure given and following the high quality CPR. And in place of hand, a sandbag, a board, or even an IV bottle can be used. So we should confirm the cardiac arrest, shout for help, commence prone CPR without wasting time in turning the patient supine. While the preparation for turning the patient supine can begin with by arranging personnel, give 100% oxygen, attach the defibrillation pads, follow the adult advanced life support guidelines. If the CPR is not found to be effective with end-tidal CO2 monitoring or arterial pressure, we should turn the patient supine. Otherwise, we can continue to resuscitate the patient in the prone position. So the most important thing is instituting early chest compressions and defibrillation. Pre-placement of adhesive defibrillation pads can be considered in high-risk individuals. So high-quality CPR should be the aim. Thank you.
Thank you, Swati Chabra. You have delivered an excellent lecture. I just wanted to tell you about my feelings about this CPR, first of all. Actually, when the COVID has established in March, there was some communications from the Western world. They have advised us not to do a CPR and all those things. But I said it is inhuman to leave a patient without doing a CPR, even though we are available. They are very much afraid of touching the patient. Then immediately we have constituted a committee in IRC and we have started reviewing the literature and doing the CPR. Of course, our guidelines have come in and published in April. And another thing is, we do not actually, if you are not well protected, we do not want to throw you into the problems. We definitely advise you to protect yourself, either with a towel or a gown or a PPE or by sealing with the plastic sheet or anything. And but do a CPR. And definitely we have seen a lot of good number of people have recovered, especially when the parents of the doctors, when they are treating themselves, when they fall in the bathroom and all, they brought them out and they resuscitated and they have recovered. So in that basis, definitely we have to resuscitate and we have to do resuscitation. And the prone CPR, definitely prone ventilation has been increased for the last 5-6 years, even though we have, because with the number of ICUs have been increased and our skills have been increased. Otherwise, we used to think that keeping a ventilation in the prone is very difficult and we may lose a hold on the tube and all those things. But we have realized that the prone ventilation is better, and definitely even now, I tell you, the prone CPR gives a better oxygenation than supine CPR. And as you told already, the placement of hand and the paddles, everything is 100% correct. The another thing is, we are making a study. Actually, The study is already sent to somebody for a review on that, whether we have to conduct a CPR or not in a COVID patient. We are already treating all these patients for the last 8-9 months, but we have collected the data and people are reviewing it. Another, of course, prone CPR also we have to do, and there is very, very little literature. And Indian Resuscitation Council and Indian Society of Anesthesiologists have formed a task force of guidelines to review the guidelines. And definitely we'll be coming with the new guidelines, definitely with the better guidelines than others. And definitely I suggest to do a prone CPR. Don't bother to tilt the patient and lose the control on the endotracheal tube and all those things. I advise only the prone CPR.
Thank you very much, sir, for all the work that is being done in this area. And we are really, the Indian guidelines are very helpful in this aspect. The COVID guidelines also and the previous guidelines we had.
Any other comments from
Patients and everything to all the medical colleges, these Indian guidelines. Please teach to your first year medical student without charging anything.
I just want to make a comment. Dr. Swati, in couple of papers, they have said to put the paddle placement, the right one in the infrascapular region and the left one in the mid-axillary line region.
Yes.
But you have shown that the right one is above the scapula and the left one is below the scapula. Any comments on these, please?
Yes, ma'am. There is quite a wide range of variation which is seen in the pad, placement of the pads. They range from anteroposterior, bilaterally in the mid-axillars, because there are no societal guidelines. What I have taken is from the recent papers which were being guided, because none of the guideline societies have provided the exact hand placements and the pad placements. So these were from the recent guidelines and from those patients who survived the cardiac arrest in prone position. So I just looked for that, what majority of the studies, or not the studies, but case reports and case series have mentioned. So otherwise, there are so many combinations for the pad placements. I agree that mid-axillary is also there.
Yeah, the whole thing is that you have to have the paddles on either side.
Yeah.
That's all.
The important thing is all the countries who are having guidelines, the 7 countries are afraid of touching the COVID patient. That's why they're not much bothered about to keep and all doing all these things and all. But definitely within 3-4 months, definitely IRC will be coming with newer things. And some of you people are there already in the task force committee. Thank you very much.
And the main idea is to get the maximum amount of current to pass through the main bulk of the myocardium. So I think this is achievable with most of the arrangements which are mentioned.
Thank you.
Thank you.
So I think, I guess we are done with the third session. Thank you very much, Chakrarao sir and Srilakshmi madam, for sharing that session. And thank you, Swati. It was a very good presentation. And so we move on to the next one, session, point of care ultrasound in cardiac arrest. So to start with, I would like to introduce the chairpersons for this next session. My slide is visible. Is my slide visible?
Yes, yes.
Yep.
So the first chairperson for this is our own Dr. Indrani Hemant Kumar Madam, Professor and HOD, Department of Anesthesiology, GS Medical College and KM Hospital, Mumbai, with 31 plus years of experience. She's got a first medal in DA and MD Anesthesiology, Mumbai University, and Hargobind Fellowship in Cardiac Anesthesia at Lehigh Valley Hospital, Pennsylvania, USA. She's the president-elect of RSSCP National, past president ISA Mumbai. She's the organizing chairperson of ASACON 2011 Mumbai, and she received awards Bharat Jyoti and Natya Kalaimani. She's having publications about 28. Her areas of interest are cardiac anesthesia, obstetric and pediatric anesthesia, critical care. Welcome you, madam. So the next chairperson is again from IRC, Dr. Rakesh Garg. He is also the GC coordinator of today's webinar. He is the additional professor, Department of Onco-Anesthesiology, Palliative Medicine, Dr. BRA, IRCH, AIMS, New Delhi. His achievements are numerous. He's got the ISC Proficiency Award 2019, the ISC Bhopal Award for Academic Excellence 2018, second best research paper, Singapore Medical Association, YG Bojraj Award for best review article, ISA President's Award in 2017-15, and also the Singapore Medical Journal Reviewer Recognition Awards, Outstanding Scientist 2015 Award, and also there's a biography where in 2016, Who's Who in the World, and the Leaders Award Healthcare for Excellence in Pain Management for the year 2015. He is the Associate Editor of JOSCP, IJA, Journal of Medical Case Reports, and editorial board member and reviewer of several international and national journals. And he's conducted numerous conferences and workshops on BLS, ACLS, ATLS, and so on, and also research methodology, delivered numerous guest lectures, more than 120, chaired sessions and judged for competitive papers, and a number of publications, more than 250 international and national, and more than 25 chapters in books. His areas of interest include pain in palliative medicine, clinical research methodology, resuscitation. So over to you, both the chairpersons, to introduce the next speaker.
Thank you so much, ma'am. And
thank you so much. Thank you so much for this introduction. Over to you, Dr. Rakesh Garg.
Thank you, ma'am. Thank you, ma'am. Thank you, Dr. Indrani, ma'am. And thank you, Dr. Vijay Lakshmi. We have an interesting session of focus in cardiac arrest. The ultrasound is an integral part of the perioperative care. It is a very important tool, and same will be the situation of ultrasound for cardiac arrest management. So we have a wonderful session of focus in cardiac arrest by Dr. Nibras Kugara, and his CV is excellent. I think he's the right person to deliver this session because he has a good amount of experience and training in this aspect. He is associate professor at Albany Medical College, New York. He is a critical care medicine fellowship from Johns Hopkins School of Medicine. He has many honors and awards to his credit. He has Albany Medical Center Patient Safety Hero Award. He is the Association of University Anesthesiologists Junior Faculty Travel Award in Perioperative Medicine, and he has received numerous awards from his students. Just shows that he is a wonderful teacher. He has special training in ultrasonography and echocardiography at various aspects, and he has been teaching in the various platforms. He is director of workshop for focus point of care ultrasound during life resuscitation. He's also a director for the workshop for transthoracic echocardiography, and he is a national and international faculty and mentor for various such programs. He has numerous presentations at national and international meetings, and he is a peer review of critical care lecture, which is a wonderful series of lectures which is uploaded on website. He is mentioned here. He has published various papers, review articles, and book chapters in various international reviewed journals, and he is definitely working a good amount of research in this area. So I think without wasting much time, I will request Dr. Dr. Kugara to continue with his deliberation on focus in cardiac arrest. Over to you.
Thank you so much, Dr. Garg, for this amazing introduction. And thank you for the Research Society of Anesthesia organizing committee to invite me to give this talk among the giants in the field. First, I need to actually share my slides. So let's do that. All right. So supposedly sharing my screen. Do you see my screen and my slides?
We can see your screen.
We can't see your slides.
Okay, because I'm not sure why you cannot see.
You have
my
to select your
presentation.
slides now. You
All
have to
right, so-
select your presentation. And we are seeing multiple,
Yeah, I did
boxes.
select it. I have two screens. One is showing me what you guys are seeing, and the other screen I'm presenting from. So there's a lag for some reason. I think we got stuck. So let me go again and share my screen again. It worked earlier. Let's see. Screen sharing ended. I will go ahead and do it again. All right, so screen, start broadcast. Okay, I think we're getting there. Perfect. All right, so I'm gonna go ahead and start. I have a lot of grounds to cover today. So I have no disclosures. Today we'll be talking about the rationale of use of echocardiography during ACLS. We'll talk about the algorithm, implementation, interpretation, potential harms, and then trainability. So why do we use POCUS in cardiac arrest?
I'm gonna do rhythm check. Pulse check. Yeah, there's a pulse. I don't have a pulse. That's a pulse. That's a pulse, right? That's your pulse. Fully different pulse, man. Here, let me. No. Oh no, what are you talking about? This is a pulse. You know what? I'm writing you up for this. I'm writing you up for this. There's no pulse. 10 seconds. We're not. We don't need to do compressions if there's a pulse, guys.
All right, sounds familiar. So we all know from medical school that cardiac output is heart rate times stroke volume, and true PEA stroke volume is 0. But have you ever thought if the heart is trying to generate a stroke volume that's too small to be palpated? We call this pseudo PEA. And this could be due to many of these etiologies. It could be due to tamponade, it could be due to massive MI, it could be due to tension pneumothorax, massive PE, or hemorrhagic shock. And we were not going to be able to figure this out on physical examination. But if we apply the probe 2 centimeters below the xiphoid process, use the liver to transmit the ultrasound, then we can have a look at the heart at the long axis. Note here, we're using a phase array probe with the indicator phasing towards 3 o'clock. Okay, so we see an image. What does that mean? In this video here, you see that there's no myocardial movement whatsoever. The only movement you can see is the movement of my probe on the patient's chest, and we call this true PEA. While in this patient, we see that the LV is trying to contract, trying to beat and generate a stroke volume, but the stroke volume is too small that you cannot feel or palpate. We call this pseudo PEA. In this situation, you can see here the left ventricle is dilated and not contracting well. In the right clinical scenario, this could be due to MI. In this scenario, you can see there's a lot of pericardial fluid around the heart with RV collapse during diastole, and this is a case of tamponade. Here we see that the RV is dilated, and with the septal shift toward the LV, crushing the LV, this is an obstructive etiology caused by massive PE in the right clinical scenario. And in this situation, you can see that the ventricles are empty and hyperdynamic. This is an example of severe hemorrhagic or hypovolemic etiology. We talked a lot about VFib and VTAC arrest. This patient has a flat line on the monitor, but when we applied the probe to the chest, we found that this patient had fine ventricular fibrillation and he needed a shock. Okay, so we see cardiac activity in ultrasound. What does that mean? In this case series, out of 11 patients who had cardiac activity on ROSC, on ultrasound had ROSC, and 0 out of 23 without cardiac activity had ROSC. This study done in Germany, done by the emergency physicians, 100 patients who had CPR, 51 of them had suspected PEA on the monitor. When the ultrasound probe was placed, they found myocardial activity on 38 of them. So this is pseudo PEA. And what was surprising is you see here with patients with asystole, 13 out of 37 has cardiac activity. The outcome for these patients in the dark bars, you can see that when patient has cardiac activity, their survival or the ROSC is much better. In this meta-analysis published in the Annals of Emergency Medicine, more than half of the patients who had cardiac activity had ROSC, and only 9 out of 378 patients who had no cardiac contractility on echo had ROSC. But the authors, for this reason, the authors recommended that the echo should not be the sole basis for decision to cease resuscitation, because as you see, some of these patients regained ROSC. This multi-center study done in the US, emergency rooms for out-of-hospital cardiac arrest, close to 800 patients, 414 patients had PEA, more than 50% of them had cardiac activity, and then 10% of the asystole patients had cardiac activity. You see here, the survival for patients with cardiac activity and ultrasound is much better than the survival for those who did not have cardiac ultrasound activity on cardiac ultrasound. The percentage here, 0.6% made it outside of the hospital who had no myocardial activity, and only 3.8% made it out of the hospital with cardiac activity. I looked at this and I was so depressed. This is a very low percentage. But then I remembered that's all done on the out-of-hospital cardiac arrest. For in-hospital cardiac arrest, the survival is much better. It's better than 18% survival out of the hospital. And the magnitude of the in-hospital cardiac arrest is similar. There's around 200,000 cases per year in the US. What was surprising is 3 out of these patients who have cardiac, who had ROSC and then discharge out of the hospital have good neurological outcome. And this is because there's a different etiology for the cardiac arrest. 80% are because of non-shockable rhythms like asystole and PEA. And these are mainly because of all these reversible causes. So if we can detect them very early, we can manage them. And again, unfortunately, on physical examination, you cannot tell. You need to really take a look inside the heart. So as much as I'm excited to put the probe on every patient who's having cardiac arrest immediately, I just want to say that our CPR goals mainly is to save the heart and the brain, and not to forget about the brain. And the only way you do this effectively and evidence-based is recognize crisis, call for help, do rapid defibrillation, and then start chest compressions. High-quality chest compressions rely on thoracic pump. And you do that by pushing on the chest for 2 inches deep, around 100 to 120 times per minute, and then allow complete decompression. So take your weight off the chest completely, and that will be enough to generate around 15% of cardiac output and generate aortic diastolic pressure more than 30 to perfuse the heart. Now, also, you need to keep the CVP low, and you do that by not excessively hyperventilate the patient. So ventilation should be around 10 breaths per minute. And when you apply these rules, you'll get a good perfusion pressure here. The moment you stop chest compressions, the perfusion pressure goes to almost 0, and then to 0. And then when you start chest compressions again, it takes some time for the adequate perfusion to get back into the circulation. For this reason, the American Heart Association guidelines in 2010 recommended early CPR and correction with the compression interruption less than 10 seconds. And then in 2015 and 2020, American Heart Association guidelines, no change, limiting the time to no compression to less than 10 seconds. So I told my residents, you guys have less than 10 seconds to obtain echo images. You can see here, there's the dreamers kind, the suspicious, and the enthusiastic residents When I talked to the suspicious kind, I tried to show him that it's really easy to get images subcostal. So he laughed at me and he goes, I hope all my patients are that thin. And then he mentioned there were 2 big studies in 2017 suggested that using POCUS and ACLS actually delay the resumption of chest compressions by 8 seconds. So I told him, in this situation, the team didn't use a protocolized approach. And protocol, I mean this. So we published the Easy ALS protocol this year. And it's basically based on the previous protocols published by the emergency physicians, the field protocol by Raul et al. And it's based on recognize crisis first, call for help, begin CPR, secure airway and oxygenation, identify shockable rhythms, and defibrillate. Only after CPR of 2 minutes, then you have a window of less than 10 seconds to check a pulse. At this point, you need to check for a rhythm, for shockable rhythm. If there is shockable rhythm, apply shock. Check for pulse, look at the A-line waveform and capnography for signs of ROSC. And in the meanwhile, the echocardiographer could be trying to obtain an image. If you couldn't obtain an image and record an image within 10 seconds, then CPR should be resumed, and then the next pulse check should be performed again. And you can do this over and over again until the patient gets ROSC. This is an example of how it's done. Hey, can you hear me? Can you hear me? There is no carotid pulse. Sinus tach on the monitor. Hey, Sean, can you start chest compression? Hey, Mike, can you call for help? Get AED and the code card? Sure. Lynn, can you help with the airway? It looks like we're in the PEA algorithm. What cycle is this? Starts here, starting 5. In 10 seconds, we will check for pulse, rhythm, and we'll get a field exam. Eric, can you break the echo? Coming with the epi coming in. 1 milligram of epi, please. Yeah. All right, 10. Epi's in. 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, acquiring images. 8, 7, 6, 5, 4, 3, 2. Resume chest compressions. No pulse.
Okay, there's no pericardial fusion. RV's moving well. He looks grossly underfilled. I think he's hypovolemic.
Hey, Mike, can you grab a bag of saline and 1 milligram of epi? Sure. No, I'm sure this is how every single code ran in your hospital. Very quiet and well organized, not chaotic at all. Well, as you see here, by applying the probe during the 10-second pause, you can actually record the images and not try to interpret them. The interpretation happens after this 10 seconds period when the chest compressions resumed, and then there should be a closed loop communication between the echocardiographer and the code leader.
Oh, look! There's a heart! Good. And they can pump ANSA. That's all we need.
So the orthopedic surgeon was happy that the heart is going to pump ANSF to the bones now since it's beating. All right, so what does the ACLS guidelines, American Heart Association guidelines, say about ultrasound? They mentioned that the use of ultrasound should not interfere with the provision of high quality CPR and conventional ACLS therapy. And they said ultrasound may be considered during management of cardiac arrest, although its usefulness is not being established. The European Resuscitation Council in 2015 said they were more specific. They said ultrasound during cardiac arrest can detect reversible causes of arrest, and they recommended specific protocols to be helpful. There is no change in 2020 guidelines. So that means using one of these protocols. These protocols are validated for all, many of them validated for out-of-hospital cardiac arrest. This is the protocol we published, which is validated, or we have at least tried on patients for in-hospital cardiac arrest. Now we'll talk about trainability. Can we train residents to do it? In 2015, when I joined the Albany Medical College faculty, I decided that it's time to start training our residents in ultrasound. I gave a grand round to the department, and I got the support for my amazing chair. So we started giving the residents one-day course. And that one-day course is composed of 2 hours of web-based video material, followed by 2 hours of lectures, and then 2 hours of small groups hands-on training. And unfortunately, with this approach, we're not reaching the, our residents will not be able to achieve competence in ultrasound based on the site of critical care medicine. You see here, the recommendation for the fellows was at least 20 hours of continuous medical education training, combined with performance of ultrasounds in 30 patients and reading, interpreting 50 studies. So we decided to get all our residents accredited. In 2016, we provided 5-day training for our PACU residents. So that means it's the CA3 resident, the PGY 3 residents. During their PACU rotation, will have 16 hours of moderated web-based lecture provided by the site of critical care medicine, combined with 20 supervised echo exams, followed by 10 indirectly supervised on real patients. And after that, we did 5 sequential team-based simulation for ACLS. This is an example of the curriculum. The lectures provided by the site of critical care medicine have tremendous amount of pathology, more than 50 cases for patients with pathology. And it covers a lot of the aspects of physiology and pathophysiology. So these are the residents in the morning watching the video lectures provided by the site of critical care medicine. These lectures are moderated by one faculty. That means we pause for the important aspects. We have the resident go up and try to explain to us what he learned from the point. And we pause for every case and we do discussion. In the afternoon, we supervise the residents to do 5 exams on real patients in the surgical ICU and PACU. Well, after they finish the 5-day course, they get a test, and then they get another test 6 months later. We compared the scores obtained by the group who had 1-day course to the group who got the 4-day course. And, you know, as expected, the 4-day course scored much better, 77% on the 30 questions test validated and made by the site of critical care medicine in compared to the control group. But what was really surprising is 6 months later, the residents were able to retain their knowledge. This is to show our residents' performance in the last 4 years, very consistent. Every single resident, we have only 6 residents per class. Every single one of them did the training, and you can see here, scores are very similar, and all of them retained their knowledge 6 months later. We took this experience to other universities, University of Vermont and Mayo Clinic in Florida. We got similar results. We just presented this at the site of critical care medicine. 41 residents from 4 institutions did this 4-day course without the simulation part. And you can see here, good scores above 70%, which is the passing line that's determined by the site of critical care medicine, and good retention after 6 months. Now, we trained the anesthesia critical care fellows, all of them in these institutions, using the same curriculum. And again, consistently, those fellows, after they finished anesthesia training, they started with these scores of around 60%. After the 4-day training, they gained much more knowledge than the residents, 81%, and they were retaining their knowledge at the end of the academic year. Now, after this 4-day training, we took the residents for simulation training. And a few things about simulation. We want to make sure that they don't get distracted by the ultrasound. See here, the ultrasound is a big distractor. We wanted to make sure that they maintain their focus on trying to get high quality CPR. Also, we focus on proper exposure for the patient before performing the exam. This is an example of one of the simulation scenarios.
Time for pulse check. Pulse check. Looking at our rhythm. Looks like a non-shockable rhythm. Do we have a pulse? How much time? No pulse. Countdown time, please. 5, 4, 3, 2, 1. Okay, can you get a milligram of epinephrine, Darcy? Yes. Let's see your hand now. Thank you. All right, guys, there's no sign of any pericardial effusion, so it's not cardiac tamponade. The right ventricle is small in size and hyperdynamic, so no increased risk for pulmonary embolus. It looks like we're underfilled. We need some volume, guys. Okay. 1 milligram.
So after this, my residents thought that they did a great job. Lots of tapping on the shoulders. I told them they did not do a good job at all because the pause here was for 17 seconds. They did not start counting after they were checking for pulse, and that led to 17 seconds pause. So this is unacceptable. We were able to show, this study done when I was a fellow at Hopkins by my mentor. I was one of these guinea pigs who did the simulation. And you can see here, the more simulation scenarios the residents will do or the fellows will do, there's more compliant on the no chest compression interruption. We got an IRB approval to allow the residents to do the ultrasound without direct supervision. So their residents' goal was to perform the ultrasound in these 10 seconds check. And the first goal is to detect if there is a cardiac activity or no, because of that will give us a little bit of idea about survival. And then they need to look for all these reversible causes phenotypes on the heart: tamponade, RV failure due to PE, massive MI, severe hypovolemia, tension pneumothorax. These are some examples of the ultrasounds performed by the residents, all in less than 10 seconds. So you can see that this image is not very clear, but at least we can tell that the patient has pseudo PEA. So there is some contractility here. Now, this patient regained their ROSC, and you can see here, the base of the heart is contracting, the body and the apex is not. This is a classic example of Takotsubo cardiomyopathy, which we see a lot after CPR due to probably the massive amount of epinephrine the patient gets. But still, according to the American Heart Association guidelines, we referred the patient for the cardiology consult for possible cath to rule out ischemic etiology. This patient coded in the OR, and you can see there's an invited clot in transition into the right atrium. So this patient had a massive PE as a cause of his pseudo PEA. This patient have the pericardial tamponade. You can see here the RV collapsed during diastole. This is the RV, this is the LV. And that patient got a needle and a pericardial window. And this patient had anesthetic-induced cardiac arrest. He got hefty dose of anesthetic, and inotropes really improved the patient. And we regained ROSC. So any time during CPR, you can apply the probe in any areas other than the subcostal area. You can look for the placement of the endotracheal tube. You can look for signs of pneumothorax. You can look at the flanks to look for massive pleural effusion, which can cause tamponade physiology. This patient had hyperdynamic small ventricles. When we looked at the IVC during chest compressions, you can see that the IVC was very full here and plethoric. See, the hepatic vein is also plethoric and full. So that patient's physiology didn't make sense. The IVC was dilated and the heart was collapsed, which tells me that there was an obstruction in the chest. So we looked at the flank and we found massive pleural effusion. This is a collapsed atelectatic lung. This is the pleural fluid with the spleen. So that patient didn't have enough time to put a chest tube. We just made an incision quickly. We drained more than a liter of fluid and we got the ROSC. So we just published a case series performed by our residents. They're all self-reported exams done in the peri-resuscitative period. Around 12 patients had PEA. 9 out of them had true PEA. Pseudo PEA. One had true PEA, and then we have one patient with asystole and one patient with VTAC, pulseless VTAC. These are the findings we found on the patients who had exams done by the residents. These are around 10 residents performed 22 exams over 2 years. And you can see here, we had ROSC 9 out of 9 patients and no ROSC in 3. Now for the patients who did not have ROSC, 2 of them had cardiac standstill initially. So we concluded that we can train our residents to perform ultrasound and ACLS. We just need to expand training to our junior residents and attending anesthesiologists. We have only small classes. We were only able to capture around 5% of the codes. And that's because at any given time, we don't have enough ratio of residents free to do the exam. And the faculty were not trained to do it. So we started training the faculty now. And we were looking to get handheld ultrasounds. Now, this study was done in 2005, and they compared students using handheld ultrasounds to attending cardiologists, board certified, American board certified, in figuring out all these issues: left ventricular enlargement, dilation, hypertrophy, right ventricular enlargement, right atrial pressure, pulmonary hypertension. You can see here, the students after limited training outperform the cardiologists. The students only get days of training. The cardiologists are board certified. They're using their stethoscope, and the students with the new technology outperform them in all areas. And when we think about echo, we think always about this complicated exam that requires a lot of time. In 2004, Jensen and Eric Sloth, they published their FATE protocol, which is a simplified approach. Instead of doing all these images for the heart, they focus only in the parasternal area, apical area, and the subcostal area, and the flanks. When they trained their ICU attendings to do it, the ICU attendings were able to get images at least one window in 97% of the time. And 37% of patients, they were able to get more information, and only 24% had decisive decisions made based on that finding. Our residents in 276 consecutive exams, they were able to find at least one window in 96.9% of the time. And the exam took around 18 minutes to perform. That's too long. So is it time to really simplify point of care ultrasound? Do we really need to do all the views, or shall we just do the subcostal view that we showed that it really works for ACLS scenarios? So we did this study in 150 patients consecutively seen by our residents and the residents in Mayo Clinic. We published this abstract in 2018. The residents were able to see good images in 60% of the time, adequate images in 20%. That means you'll have an image that potentially will answer your questions in 4 out of 5 patients when you apply the subcostal view. We compared the findings from just the subcostal view to the full FATE exam, and there was 96% agreement. So then by doing one view and by teaching one view, we could potentially expand the users. We can introduce the users to use ultrasound, and we have more anesthesiologists to try to do it. So this example, this vascular patient, pre-op, I didn't know anything about his heart condition. I can see here when I did the EZ that he has biatrial enlargement and thick LV. When I turned the probe 90 degrees, I was able to look at the IVC. You can see it's small and collapsible. So that patient received IV fluid bolus before induction, because this patient is high risk for hypotension after induction. And the entire exam took around 2 minutes. So if we focus on teaching one view, we can expand our users. We sent 5 faculty to learn the full 40 exam a few years ago with the Society of Critical Care Medicine. And 6 months later, I checked with the 5 faculty, only one of them was using ultrasound because it's too much data, too much information to learn in a 2-day course. But when we started training our attendings on one view only, we trained so far around 20 attendings, and they are using the ultrasound. And we link this to our ACLS. Hypotension all starts with, these are the progression types of hypotension. Type 1, they all resolve. Type 2, respond to intervention. Type 3 will end up with cardiac arrest. If we can catch these hypotensions early by ultrasound, we can prevent cardiac arrest, which is better than getting ROSC. Also, here's an example. This is a patient who is having a history of severe COPD, presented for left lung decortication. Right after induction, the pressure went down to 50/30. They called me to see the patient. I was really busy. I couldn't see the patient, but I sent one of my interns who got the easy training to do the ultrasound. And once they arrived to the OR, they placed the probe at the subcostal area. And you can see here, the RV is much bigger than the LV. And this is a case of acute cor pulmonale. So the anesthesiologist at that time was giving fluid to this hypotension. So we stopped the fluid and we started vasopressin to improve the RV perfusion without affecting the pulmonary artery pressure. We started milrinone to improve contractility. The beauty of the subcostal view, we'd done it immediately after, and you see how the LV is now filling much better. And that patient actually had a MAP about 65, and the surgery was canceled, but we got a ROSC. Okay, so in summary, I hope I convinced you that the focused cardiac ultrasound during ACLS can be both diagnostic and prognostic, because it has the ability to differentiate between true PA and pseudo PA, and also it helps you identify the reversible causes very early. But it's really important to be compliant with the ACLS guidelines, is to remember to minimize interruption for chest compressions less than 10 seconds. I'm not sure how I'm doing with time. I hope
No,
I didn't exceed my time.
No, I don't think you exceeded. Thank you very much for a very lucid presentation and excellent videos. I mean, we thoroughly enjoyed looking at them. And as you rightly said, in our curriculum, we do have workshops for our residents, but as you said, we have a simulation-based workshop for just about a day, and I know that one-day workshop is not going to help. You're very right. We have to reiterate it, and we have to do it for at least 4 or 5 days for them, and especially if you have to use ultrasound for CPR, then you really have to be quick. Not only quick, you have to be confident and you have to know what you're saying. So, and for that, you need a lot of expertise and experience. Thank you very much for a wonderful presentation. And about questions, I myself had a question saying that in your PACU, do you always use ultrasound to know how well you resuscitate? Or is it done only if you are in doubt whether about the cause of the cardiac arrest?
So after we validated using only subcostal view, then the time to get the ultrasound reduced significantly. So right now, when we have a PACU resident, we try to do ultrasound in all hypotensive patients in PACU. Anyone with acute respiratory failure or hypotension will get the easy exam. Now, in 80%, they will get images, and 20%, if they can't get images, then they can extend their exam to the other views, which they also know how to do it. And that happens only in around like 20% of the time. So
what about CPR? What about CPR?
CPR, if the resident is available, if he's not covering a case, because our CPR usually an attending and a nurse anesthetist go to intubate the patient. But
no, do
when
you
the
use
resident
ultrasound in all your CPR?
Yeah, I'm coming with that. So when the resident is available or the attending knows how to use the ultrasound, then they use them. Unfortunately, that happens only less than 10% of the time, because the majority, we're still building our attendings, trainees, and right now we're training the residents in all years. We did this course 3 times during their residency. So we're trying to expand in the use, but I'll tell you that the rate of cardiac arrest we capture with ultrasound is less than 10%.
And I liked your thing saying that in a kingdom of blind men, the one-eyed man is the king. Anesthetists have both eyes open. Very true, very true.
Yeah, here, you might not be the expert, but it's better than not seeing anything, better to try.
Right, very
as
true.
long as you don't harm the patients, because really, if you are interrupting chest compressions more than 10 seconds, you might hurt the patient, as I showed, and as it's continuously. So as long as you are safe, that's why we do the simulation. We try to imprint this in our residents so they don't exceed the 10 seconds.
No, that's why I said you need to have a lot of experience to understand, to diagnose within those 10 seconds.
Correct. So what we do here, and then 10 seconds, they only record the image. So during 10 seconds, they have to record the image. Now, during the 2 minutes of chest compressions, they review the images, and then once they have a conclusive findings, then they communicate this to the code leader.
Yes. Thanks. There's another question. Will focus be useful if used in patients with hypotension in OR after spinal anesthesia? I think you answered this question. You answered
Correct.
the question. I mean, a hypotension of any cause can be identified with the focus. I think you answered it. And there are a lot of people who have given, who said that your presentation and videos were excellent. And if there are no more questions, we can go ahead. Thank you so much, Dr. Nibras. It was an excellent session and an excellent learning session for us. Thank you very much.
Thank you so much for inviting me. I just want to add that we are running the simulation courses at the PGA for the last 3 years. And we placed a proposal for the ASA to get them. So if any of you would visit the US, you can go over and get the courses that which is validated with our residents.
Thank you.
Thank you so much.
You're welcome.
Thank you so much. Over to you, ma'am, Dr. Vijayalakshmi.
Over to you, Vijayalakshmi.
Thank you so much, Chairperson Sunyani ma'am and Rakesh Garg sir. And thank you, Dr. Nibras. I hope we didn't delay you going for your call, or if you're not having any call, please continue with us for the next session too. So thanks a lot for that excellent presentation once again.
Thank you. I love at 10 o'clock, I have to start a simulation training for ventilators for the residents. So I can stick around till 2 minutes before 10 probably.
Okay. Thank you so much. So we'll move on to the next session, the final one, which is a very important one, debriefing post CPR. So to session, I invite the next session chairpersons, Dr. R. Gopinath sir, Professor and HOD Department of Anesthesia and Intensive Care, ESIC, SSC, MCH, Sanat Nagar, Hyderabad. He delivered various orations, the PN Tota, Punus, he did our PN Bhatt, Dr. V. Kamath orations. He was the past president and chair, Education Cell, IACTA. He has publications more than 150 as first and co-author, and his areas of interest are cardiac anesthesia, pain relief, and critical care. And welcome, sir, to chair the session. And the next chairperson for today is Dr. S.K. Singhal, sir, Senior Professor, Department of Anesthesiology Critical Care, Pandit B.D. Sharma, PGIMS Rohtak. He has got 32 years of experience in the research guide to many projects and an examiner. attended various international national conferences. He has publications about 40 international and 72 national publications, and his areas of interest include CTVS, acute pain management, and regional anesthesia. Over to you, sir, both of you, to welcome today's speaker.
Yes, Dr. Gopinath, please go ahead. It is a pleasure to see you after a long time.
Gopinath sir, you have to unmute yourself. Sir, please unmute yourself. Gopinath sir, unmute yourself.
Sir.
Sir, please unmute yourself. Dr. Gopinath sir, can you just unmute yourself? Not able to. You're unmuted already, sir, but I'm not sure why it is not coming.
Some internet problem.
Dr. Singhal sir, would like to introduce the speaker. I think there's some issue with the mic of Gopinath sir. He's unmuted, but we are not able to hear him.
Maybe with the internet. Should I go ahead?
Yes, sir.
Okay. Some audio, some what I see. Can you?
I think Gopinath sir, some issue with the audio on your side, sir.
Should not.
Sir, I'll just mute yours. You can again unmute yourself and try and see. Just a second, sir. So, Singhal sir, I think you can just introduce the speaker. I think he'll join us again.
Okay, yeah.
Yeah, just a second, sir. You're able to see the screen, sir?
Yeah.
Yeah, you can just...
Some noise is coming in the background. Are you able to listen to me?
Sir, yes, sir.
Okay. It's my pleasure to introduce Dr. Neha Singh. She is additional professor in All India Institute of Medical Sciences, Bhubaneswar. And her achievement are, like, she has been winner of WFSA Innovation Award in 2015. She is a reviewer of various national and international journals. She has around 30 international and national publications to her credit and a chapter in the book also. And areas of interest are regional anesthesia, obstetric anesthesia, airway management, and onco anesthesia. So we welcome Dr. Neha Singh, all over from the Bhubaneswar. The weather, I think, must be pleasant there. Dr. Neha Singh, please.
Yes, sir. As compared to Delhi and down north, I think it's quite better here. Since I have experience of the Delhi, Lucknow, Pondicherry, and Odisha everywhere, so I think I'm in a better place weather-wise.
Yeah, sure. Please go ahead.
Yes, sir. So, yes, I hope my screen is visible.
Yeah.
So, am I audible?
Yeah, make it full screen.
Yes, sir. Yes, sir, I'm making it. Okay, so so we have come to the concluding sessions now, and I think I'm the only person here standing between you all and your dinner. So without wasting time, greeting from my place, that is in Bhubaneswar, Odisha. That is a place of Lord Jagannath. I'll be discussing about debriefing post CPR, which is yet one untouched topic, I should say. and there is no disclosure and no conflict of interest from my side, and we'll be discussing this topic in short with the headings of what is debriefing, why it has been done, when it has been done, and whom to involve. There are various types of debriefing models involved in this thing, and tools and strategies involved, and at the end it will be conclusion. So now coming to debriefing, if we'll go with the dictionary meaning of debriefing, these are the operation completion reports which are submitted by the soldiers or the diplomats after completing some task. The concept initially introduced in the military, and from there Mr. Michel took it in 1984, and the pertinent principles applied to the medical has been given in 1992. So now coming to the definition of debriefing, it's a dialogue between two or more than two people with the goal of decreasing effect of stress associated with the event. Like in the military also, they have introduced this debriefing for the psychological care of the combat who is coming from the war zone. So in the medical field also, it has been introduced with the decreasing effect of stress, and initially it has been tried with the nursing, and further it has been elaborated to the residents, and now it's widely used all over the world. It has also got the improving, it has also got role in improving future performances once the same task has been repeated, and patient care and outcomes. So all the critical incidences and CPR, it's very applicable. It is also involving discussion of the actions and encouraging reflection on the thought process involved in the clinical event. So it involves whole team, including nursing, pharmacists, residents, physician. So now coming to the concept that why are we talking about debriefing after CPR? Why do we need that? Whether the CPR is successful or unsuccessful, that doesn't matter. Why at all we used to do it? So it is very useful nowadays for all these critical incidents, specifically in emergency department also. A lot of literature is there, mainly involving the emergency department. So the whole resuscitation process is very complex and emotionally stressful and draining process. Specifically for the beginners, new residents, GR1 and all, when they are attempting all their efforts during a CPR and still they are not getting results and all, it's really emotionally draining. And these repeated stimulus may lead to post-traumatic stress disorder later on, which can go undiagnosed and all. So this debriefing used to make a stress buster sort of thing, and further future performance also can get improved. It allows the staff to discuss and process the event. It also allows relevant learning and emotional motivation and enhance retention also. Once the event happened and something goes wrong or something went well, so once we'll discuss the thing, the whole team used to discuss the thing, retention is always better, and it identifies the opportunities for the improvement at the individual level, team level, and system level. So it is not only the technical aspect which debriefing is dealing. It is also the non-technical aspect which is getting developed through these debriefing sessions. So now coming to whom to involve. So participants are from multidisciplinary team, as I have already discussed, that nursing, whosoever involved in the CPR attempt, all should be the part of this debriefing session, along with the facilitator, who should be a subject expert and preferably trained. Nowadays, standardized training for CPR facilitators are there. So trained facilitator can conduct the session better. So different qualities of the facilitator include subject expertise, and he should be able to engage all the learners in the process. And during the course of the discussion, he should be able to pick the signs or alerts when there are differences in the perspective and emotions. He should emphasize on the teamwork, and he should focus on the development of the solutions for the performance problem. So it has got a huge role and huge responsibility to go ahead with the main goals and objective of the debriefing session. There should not be the main hindrance for the debriefing session are the ID identification or pointing fingers on each other. If something goes well, something goes well, that's okay. Everybody is ready to take the credit. But if something goes wrong, then there is a finger pointing that you did something, you did that mistake, or she did that mistake. So that should not happen during the debriefing session. If something went wrong, that activity should be picked up, and we should focus on how that should not get repeated in the next session. So that part has to be taken care by the facilitator. So he should establish some ground rules so that those rules has to be followed by all the participants. And the environment should be psychologically safe. Specifically, when we are involving nursing, we are involving pharmacists, we are involving residents, doctors, and even the doctors from the different specialties. Suppose somebody is from anesthesia, somebody is from medicine, somebody is from pulmonary medicine. So there should be a psychologically safe environment. Everybody should feel safe that, okay, now we can discuss openly with all these issues. Facilitator also should focus on the primary goals and objective. The discussion should not get deviated from the primary goal, and he should use active listening throughout the debriefing session. Clarification and expansion of the discussion points has to be done by the facilitator, and he should use open-ended question to encourage the reflective learning. Like there should be the question, open-ended means there should be the question which should not get answered with simply yes or no, so that every participants will come up with their perspective, and the more healthy discussion will happen during the session. So now coming to the timings. So according to the timings, we have divided debriefing session into hot sessions, that means immediately after the event, warm sessions which used to happen hours later, and cold session which used to happen days to weeks later. So there are studies, but none of these single method or single type has been proven superior to other, and they have suggested that it has to be chosen according to the local needs. Like you can go ahead with the hot debriefing or warm debriefing or cold debriefing according to your setup and your feasibility. So there are pros and cons of all these methods. Coming to the hot debrief, the plus points are availability of all the staff then and there and minimal recall bias. So people, the event is fresh and they can immediately discuss the things, and urgent issues can be addressed immediately. But on the opposite side, the limitations are time spent on code, and the nursing staff and all, they must be having patient care priorities and other work also. Emotional readiness, the resuscitation process is emotionally drenching, specifically if the attempt is unsuccessful. So the attendants may not be ready for the immediate debriefing session and all, and availability of the location also is a limiting factor for hot debrief. Now coming to warm debrief. So again, the plus points are team availability. Staff can complete the postcode because some time we are giving, it is between hours and all. So more planned, a bit more planned than hot debrief, and location can be reserved. But here again, the negative factors are participants may be scattered due to time bound services, and there could be loss of enthusiasm amongst the participants for the debrief. Now coming to the cold debrief, there we can get, it's a totally complete selected environment, so longer time for discussion can be chosen, and it allows emotional settlement also of the participants, so they can be more fresh and all. But again, the cons is difficult to pull the same team together on board for a debrief, and it is time and resource consuming because you need to sit back, you need to see for the location and convenient time for all the participants to conduct a cold debriefing session. So there are pros and cons of all the approaches. According to the local setup and local needs, we can choose any of the model of the debriefing. Now, how to go ahead with this? Choosing, first of all, as I said, we need to choose a model, and then we need to standardize the format by choosing various tools or checklists. Because every time we cannot change the checklist or tool, that all the debriefings, suppose we are doing a CPR debrief, so all the CPR debrief should have a common tool and checklist so that the things and outcomes can be comparable afterwards. With this whole sole purpose here is to understand the actions, decisions, education and emotional processing behind any of the action. There should not be any ID error, finger pointing or blame game during any of these debriefing sessions. So there are different debriefing model, including of 3 or 4 steps. So here we are dealing with the model where it consisting of 4 steps: description and reaction is the first step, analysis and application can be there, and summary. So coming to the, somebody is scribbling a bit, I think. I don't know whosoever is it. Please stop this and you can rub it off. A bit of scribble is there on the slides, not from my end. Sorry for this. Yes, now gone. So now coming to the description and reaction. The first step is description and reaction, which include brief overview of event and staff action. So facilitator will briefly introduce the overview of the event, what has happened, and what actions has been taken care. It includes patient condition and intervention, and we need to develop shared understanding of the event. It is followed by analysis, which used to explore rationale behind behaviors and actions. Suppose you have asked, as a team leader, first of all, as a team leader, if you have asked allotted a role and you have asked someone to do something, like pharmacist, you have asked to load adrenaline, you have announced and she has loaded or she has not loaded or she has delayed and all, whatever happened has to be discussed, and why it has been happened, it has also been to discuss, because there are a number of reasons, that is because of non-availability of the drug, or some systemic issues could be there, or some other modified factors could be playing a role which can be modified. So the main reason is why it has happened and how it can be improved. So we need to focus on that during the analysis session. So again, there are this model used to use different tools like plus delta and plus delta plus. In the plus delta model, we used to ask 3 questions. Whenever we are doing debriefing, it's not only for debriefing. As such, whenever we are doing a counseling session or any of the session, we should always start, as a communication skill, we have to always start with a good thing first to cheer up the boost morale of the participants. So we have to discuss good, bad, and conclude with good. If something goes wrong during the session, that has to be discussed during the event, that has to be discussed in between. So first of all, we have to ask what went well. That has to be first thing. And what would you do differently next time? That is the second question. And were there any safety or equipment issues? This is the third question of plus delta model. But rather in plus delta plus, which is used in bomb session, we are using 3 more questions, that whether there was a clear leader. Sometimes due to confusion, the whole team doesn't know who is playing the leader part. The person who is at airway end, or the person who is doing the chest compression, the person who is loading the drug. So many times pharmacists and nursing staff are not available every time in Indian scenarios. Sometimes we are doing CPR 2 residents, one faculty, and 1 nursing staff only. So there should be a role distribution immediately once the code is announced. So was there a proper leadership announced? Was specific role assigned? All these questions has to be asked during the plus delta plus session. So now in the cold debriefing session, we can add structured presentation and discussion, which are usually not possible during the hot and warm session, because there is not much time if we are doing debriefing within hours. So there is not much time to prepare this structured presentation with all the patient data and outcome variables. Here we are checking for both technical skill, like skills, action, and intervention taken, and more importantly, non-technical skill, that is team dynamic. How the team behaved. Was there proper communication between them? Was there a leadership quality amongst the person who took the responsibility of being leader and guiding the sequence later on? So all these steps we need to check to ensure individual and group reflection on the deficiency to understand why it occurred. So we always need to focus on the deficiency and the reason why it happened. And the whole focus, it should not get repeated in the next session. So coming to the application, again the same question, how can we improve next time? That has to be the focus, and we need to create a by the facilitator for the next time event. In the summary, we need to recap with the main learning point and action plan for the deficiencies. If we feel amongst the participants, somebody needs counseling and supportive services, that has to be also offered during the debriefing session. So again, this beef burger model is there. There we are having 3 steps, that is set stage or set induction by the facilitator, followed by dialogues which include analysis and application of the event during the session. This has to be followed by the closure or summary statement, we should, whatever discussion regarding positives and negatives has to happen during the dialogue session, and during the closure, all the good thing has to be discussed, and we need to focus that whatever went wrong should not get repeated. So the key learning point has to be focused during the closure. So there are few studies in the emergency department and even pediatrics and infant studies where they have used different debriefing model, cold debriefing model, and the debriefing model as a formative feedback in the nursing station. And one more study recently in 2020 has been published, hot debriefing in the emergency department. So all these studies have compared, they have not compared different models, they have just taken one model and they are exploring those models here, and they have come with a conclusion that any, whether it is a hot debriefing or the cold debriefing, all the debriefing model has improved the psychological impact of the event on the clinician and nurses, and definitely patient care. So to conclude the session, debriefing as such identifies both excellence and opportunities for the improvement in performance on the individual level, team level, and process level. So it is dealing with both the technical and non-technical skills. So during session, usually non-technical skills are untouched throughout our teaching or throughout our training, I should say. That non-technical skills are checked during all these sessions only. Those like how to build a team, how to communicate with the team, that has to be properly trained, that has to be properly taught to the newer generation or whatever PGs now we are teaching through the simulation-based scenarios. So their debriefing sessions used to be good, and preferably if the CCTV is there or camera session, like we can put a camera to the whole scenario in the simulation session, and then we can debrief that video afterwards, what went wrong and what steps has to be taken and all. So it used to enhance clinical learning. It is very, so many nursing studies are there, it is very useful for the psychological well-being of the nursing staff after the CPR or a critical event. The only thing we need to standardize is the tools and checklist which we are using during these debriefing session. And we need to standardize the facilitator training also for these debriefing session, because facilitator has a huge responsibility of the success of this debriefing session. So I hope we will use debriefing session more often from now onwards. Thank you all for the patient listening and be with me here till now. Thank you, sir.
Am I audible now?
Yes, sir.
Oh, thank you. I have logged in through my phone. Thank you, Dr. Vijayalakshmi, and for all that. And I think, Dr. Neha, you rightly concluded that, this being a concluding talk, we need to be debriefed now.
Yes, sir.
Basic thing is that this is the basis of any simulation program, but you go through everything, and then at the end of the session there is a debriefing for, it's not finding fault with anybody, it is just to improve our efficiency in terms of cooperation, coordination, communication. All these are non-technical skills, as we are well aware, and Dr. Neha has given us an excellent lecture on that. And the only issue is that we don't have such teams of facilitators and coordinators. So we need to build all these teams. Most corporates do have these, but they are also not effectively used. So the end of the day, there is no recognition in any process where teamwork is involved. Teamwork means it is a collective effort, and every teamwork, each member is as responsible as the other. The team leader's responsibility is to ensure that the whole process is done in a very calm manner, whether it is hot, warm, or cold debriefings. And that is where you learn from your mistakes or whatever has happened during the process of CPR or any event for that matter. So, Dr. Neha, I don't see any questions from the audience at this moment. And if there are any others amongst the panel or the hosts who wish to ask you, I think Dr. Pankaj has the JIPMER has this a simulation set up there, and they do this on a very effective manner. and maybe he can add something to the talk or to the lectures or about the process, because debriefing is very important. Like I said, there is no recrimination involved in this. Essentially, whenever there is a team, the team leader should rotate. It's not that one person becomes a team leader. So it's a nomination process. So somebody who's picked up, and everybody, he might be a junior person, but his voice should be heard, his instructions should be carried out, and there is no place for ego in teamwork. So whenever there is a team leader, whoever his, whatever his stature or status in the hierarchy, his word is final. And for this, adequate training is very much needed, and all of us have to go through this process. And the most important thing is there should be no ego involved, and we should be willing to listen to somebody who's telling us things to be done in an orderly manner. So that is the process of simulation learning and debriefing, and this is very useful for a process like CPR, especially when you have between inter hospitals. You can always check to see whether the other hospitals have a similar process, whether you can learn from them or you can impart something to the other hospital or the other group. So this starts with us. So we should, maybe RSSCP can take a leaf out or a page out of the book and start such a process of having all this kind of activity going on. Dr. Vijayalakshmi, you would like to conclude or ask anything? I think we are finished with this. It was an excellent session. Thank you. Dr. Singhal, would you like to say something?
It was my pleasure to see you, sir, after a long time. And Sri Lakshmi, my colleague from PGI also. Thank you.
Same here, Singhal. Wonderful seeing you.
So the RSFP has put a very nice topic chosen for today's talk. In fact, I was going through the debriefing. Like, of course, in India, we are not practicing it much, but the studies have come from Europe and from other countries. It has improved the quality of CPR. Means like quantitatively, it has improved the quality of CPR. And moreover, there are also now program for training the facilitator, who is doing the debriefing. That facilitator has to be also trained. So that is also one component which I think need to be addressed, and maybe our leaders or our associate like Dr. Naveen and those who are at the helm of it, Dr. Chakra Rao, they can come out with some more such kind of platform, or can like we can get some CDs also. If you make for cold debriefing, if they recorded CDs or programs are there, where you can just make the student learn that these are the steps where you can miss the points, or some role play can be there which can act as a debriefer in the future to come. I think this was a very nice talk by Dr. Neha Singh. She had tried to cover almost all the aspects. I congratulate Dr. Vijay Lakshmi for this nice day, today's webinar.
Thank you, sir. Thank you so much, sir. So if there are no further questions, I think that's the last session. If any other questions are there or any other comments from the side of IRC, Rakesh, sir?
I think a wonderful session. The IRC will go a little further on to incorporate these things in future. I think ultrasound is need for the day, though we have limitation of availability of ultrasound across India. So probably in coming time, as and when the things would be there, obviously the Indian Resuscitation Council along with ISA and other bodies which are involved in these guidelines will take this step. And the session for briefing and debriefing remains one of the important aspect. I think we need to emphasize a little more from the IRC side for the role of briefing and debriefing apart from the basic routine conduct of various steps of the resuscitation. So I think Dr. Chakra Rao, Dr. Naveen Malhotra, and the all dignitaries will take this step forward so that we can go ahead with more guidelines forthcoming for the betterment of further guidelines by the Indian Resuscitation Council, and so that we can incorporate those things also. But simultaneously, I think we also need to remember that the POCUS, the point of care ultrasound, these things are becoming the routine bedside tool for the perioperative care. But on the similar side, these are not available at many places. There are many issues for the use of ultrasound because of the rules and regulations of different states. So I think we need to influence those people also, those who are licensing authority in different states, so that the ultrasound can be used at various places. Now, issue remains with the ultrasound is that somebody has to earmark the place, somebody has to earmark the person who will be using it as per the statutory requirement of those issues. So we also need to take those care because CPR can be done at any place at any time. Ultrasound has to be available immediately. So I think we have to work on multi-pronged guidelines on one aspect, administrative aspect is the second part, and third will be the teaching and training tools, because one of our speakers very well mentioned that the time is of essence even for CPR. So for a novice learner, because when I learned ultrasound, say 10 years back, I used to take not seconds, minutes, sometimes many minutes. So those many minutes may not be good for those things. We have to have good mentors for this, and probably the training of trainers program would be a very good options. I think RSACP can take a lead in this, that we can have a training of trainers program for ultrasonography with regards to the CPR also, so that people can learn and disseminate the advanced knowledge into Indian scenario also. So I think a good session, and very big congratulations to Dr. Vijayalakshmi for a wonderful session and wonderful speakers giving a lot of good knowledge. And I think we were able to revise many of the new things also. Over to you, ma'am.
Thank you, Dr. Vijayalakshmi and Dr. Rakesh Garg and Dr. Singhal sir. Thank you for your, and Dr. Gopinath sir. Thank you for your inputs, and we should definitely work over it together. And I also place on record deep appreciation for all the speakers. They were really very, very excellent. And we also learned a lot today, academically as well as clinically. And all the speakers were very good. And I'll request the office bearers, Dr. S.P. Sharma, President RSCP, is now there with us, and to say a few words. And Dr. Paul is also there, Dr. Anju Grewal, Dr. Reema Meena, Dr. Savita Sani, Dr. Ashish Diwan. If anybody wants to make any comments, you are most welcome. Dr. S.P. Sharma, sir. Please unmute yourself, sir.
Very good evening, and really it's a very excellent webinar. I congratulate Dr. Vijayalakshmi, organizing secretary, and Dr. Joseph, organizing chairperson, and governing council member, coordinator for the webinar, Dr. Rakesh Garg, for their excellent presentation of the organizing of this webinar. The society also extends its gratitude to all speakers and chairpersons who spared their time and who have shared their knowledge and experience. In fact, all speakers spoke well. Topics are very interesting, and the important thing is that, especially this debriefing and this focus ultrasound is a very important part, and it definitely makes a difference in the finding the etiology as well as for therapeutic purpose also, resuscitation also. So I am really thankful to all speakers and chairpersons, and this was a really excellent webinar with the interesting topics, and I convey my appreciation to this team, whole team, and at the same time I will say that the participation is definitely have increased, and it was a number of participants are also good, and beside this, the important is other RSP members or past presidents have also joined it. It's our great pleasure, and thank you very much. Good luck.
Thank you, sir.
Dr. Paul, sir, few words. You are muted, sir. Sir, you are muted. Dr. Paul, you are muted.
It is, hello, is it okay now?
Yes, sir.
I am very happy and excited to see that the level of the quality of RSSCP webinars have increased tremendously over last few months. Today's webinar was really very good. The number of participants have increased. The speakers were superb, all of them. The topics were interesting, very valuable topics. The selection of the speakers, the topics by Dr. Vijayalakshmi and Dr. Garg as the organizers and the RSSCP Puducherry was really, really very good. I am very happy today. And I must congratulate whole of the team, the speakers, the chairpersons, and definitely the audience too. And last but not the least, as I always say, that nothing is possible unless the dynamism and the mind of our dynamic Dr. Naveen is there. RSSCP remains indebted to you, Dr. Naveen. You have been doing an excellent job. God bless you and God bless RSSCP. Thank you very much.
Thank you, sir, for your kind words. So over to Dr. Vijayalakshmi for the conclusion.
Thank you, sir. So I wanted to at the beginning thanks to the previous chairpersons. I haven't thanked Dr. Gopinath sir and SK Singhal sir and the speaker Neha Singh. It was an excellent talk. So as we come to the end of this rigorous discourse and exchange of a lot of information on CPR, I wish to express my gratitude to each one of our participants who have actually logged in from various parts of India and the world for this interesting session. So the delegates make the session interesting. Thank you, all of you delegates. And I wish to thank each and every chairperson for today's sessions once again. Dr. Vijayanand sir, Dr. Suman Lata madam, Pankaj Kumar sir, Chandrakant Patel sir, Chakra Rao sir, Sri Lakshmi madam, Gopinath sir, SK Singhal sir, as well as Indra madam and Rakesh sir, for your experienced insights into the topics covered. So I also wish to express my gratitude to all the dynamic speakers of today, so who made it a successful session: Dr. Anvesha Swain, Dr. Sai Sharan, Dr. Swati Chabra, and Dr. Nibras Bugrara. He's left, I think he has to go for a call, and Dr. Neha Singh. So for delivering such information, which would definitely take the knowledge level of all the delegates to the next level. So I express my heartfelt gratitude to the GC coordinator for today's session, Dr. Rakesh Garg sir, for his valuable inputs and guidance in organizing today's webinar. And I wish to thank each and every member of my own RSCCP family, founders HL Kaul sir, Tej Kaul sir, President SP Sharma sir, Secretary Naveen Malhotra sir, past President Akbar Singh sir, Yat Mehta sir, President Indrani madam, Vice President Shadbari madam, Treasurer Sunil Sethi sir, Chief Editor Anju Grewal madam, Joint Secretary Vishal Singla, and each and every GC member, Rima Mida madam, Balavenkat sir, Subhendu Sarkar, Rekha Das madam, Nibedita Pani madam, Dr. Colonel Rakhi Goel, Dr. Sanjeev Palta sir, Navdeep Sethi sir, and Mayank Masan. Thank you all for your constant support and encouragement. And I thank my head of department and organizing chairperson, Dr. Joseph Rajesh sir, for helping out in smooth conducting of this webinar. And thank you. See you all in the next interesting academic webinar very soon. And thank you all and stay safe. Long live RSCCP.
Yes, long live.
Thank you. Thank you.
Thank you.
Thank you, everyone. Good night.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Long live RSSCP. Thank you, Dr. Vijayalakshmi. Thank you. God bless you. Excellent. Superb. Very, very good. Very, very nice. God bless. Thank you. Thank you. Thank you.
Thank you, sir. Thank you so much for your kind words also, sir, as always. Thank you, ma'am. See you soon.
Thank you. Thank you all. Thank you.
Good night, sir.
Thank you all. All of you. Thank you.
Thank you.
Thank you, Dr. Sharma. Thank you. It
Thank
was really very nice.
Thank you. Thank you very much. So nice to see you. Right.